Okay, welcome to the next module. This is a pretty long module, but it's a combination of pathophysiology and pharmacology. Very hard to explain one without the other. So you really need a bit of pathophysiology to understand the pharmacology. Anyways, this first slide is just a reminder to have a good idea of some normal lab values, such as sodium, potassium. What's your normal creatinine? What's a normal BUN? A glucose. Okay. Knowing your white blood cell count approximately. Every lab will be slightly different. So if Ameritech uses 5 to 10,000, possibly another place might use 5 to 11,000. So every place, every lab has slightly different parameters. Knowing what your normal hemoglobin is, your platelet counts is a good idea, your hematocrit, and then of course your clotting times. So for example, INR. So INR, if you're not on warfarin, is usually around 1. So look, they have a range there, 0.8 to 1.2. Your PTT, if you're not on heparin, should really be between 25 and 35. Okay, seconds that is. And your PT, your prothrombin time, is usually around 10 to 13. Remember, PT has essentially been replaced by INR. Around the world, okay? Because PT was giving different values at different laboratories, so it became very confusing to try and understand a PT from Utah if you were in Maine, for example. So they made it much easier when we converted to international normalized ratio, okay, which gives an accurate number wherever you are in the world when you're on warfarin. And typically we like to see INR between 2 to 3 when you're on warfarin, say for a blood clot such as a DVT or a PE or atrial fibrillation. And we often like to see it between 3 to 3.5 to 4 even when it's being used in a patient with a prosthetic valve, so a metal valve. Okay, so INR is always even thinner if you're on a mechanical valve. Okay, so 3 to 4 compared to usually 2 to 3 for most conditions. Okay, so let's move on here. Okay, so this module is on the endocrine system and diabetes, which is also part of the endocrine system, but it's its own section at the end of this module. So it's a large module. It'll have a lot of information in it. It'll have a lot of pathophysiology in it, which I think will help you understand the medications even more. Okay, so we'll move on here. Okay, so what is the endocrine system? So really, it's a series of glands that secrete hormones, okay? Compared to the exocrine system, which are organs or systems that secrete out of the body. For example, the pancreas has an endocrine function by releasing insulin and glucagon into the bloodstream, but it has an exocrine function by secreting digestive juices into the gastrointestinal tract. Okay, so we're going to be concentrating more on the endocrine system and the hormones that are circulating in the bloodstream that are released by glands. Okay, now when we talk about the endocrine system, which is hormonally based, which are these chemicals that are going to circulate in your bloodstream and attach to receptors in different organs around your body, it's typically a slower process compared to the autonomic nervous system, such as the parasympathetic or the sympathetic system. Hormones need to be released from the gland, they need to get into the bloodstream, they need to make it to the receptors, they need to activate the receptors and then have the effect on the cell. That all takes time. Compared to the autonomic nervous system that can send a signal very quickly to a target organ and have an effect within seconds. So an example of that is, say you have a very frightening event happen. Well, within seconds, your eyes will dilate, your heart rate will go up, your blood pressure will go up, and that's all because the sympathetic nervous system was activated. Okay? Hormones don't work in that way. They can't respond to second adjustments such as heart rate, blood pressure, pupillary dilation. Okay? So the main role of a hormone that's secreted by any gland is to be responsible for maintaining a part of homeostasis. And hopefully by now you've heard that word many times, because your whole body wants to stay in homeostasis. It wants to stay the same. Okay? So whether we're talking about blood pressure, heart rate, pH, all these different parameters, your temperature, all these different parameters are constantly being adjusted in the body. Okay? And that's what homeostasis is all about. Now, the other thing about hormones is when a hormone is secreted by a gland, there's typically a mechanism where once the hormone level has reached a certain amount in the bloodstream, it's able to shut off the gland that's secreting it. Okay, so that's called a feedback loop. So, say for example, a gland in your brain is secreting lots of hormone. There's an ability of that gland to reduce levels of secretion once that hormone has reached a certain level in the bloodstream. And we'll talk about feedback loops a bit later. Okay. Okay, so when hormones are released by glands, the cells that they affect are called the target cells. And the target cells will have receptors on them for that specific hormone. Okay, so it really depends on whether the cell has a receptor on it for a particular hormone, whether it's going to be affected or not. So if a certain cell doesn't have a receptor on it for the hormone to attach to, the hormone won't have any effect on that cell. Okay? So most receptors are proteins that are sitting on the membrane of the cell and are waiting for a particular hormone to bind to them. So let me give you an example. There's a hormone that's secreted by the pituitary gland that we'll come to that stimulates the thyroid gland to produce thyroid hormone. So because the thyroid gland has the receptor on it to accept this hormone coming from the pituitary gland, it will be affected by it. The rest of the body really doesn't have much of those receptors, so all the other cells in the body won't see this hormone coming from the pituitary gland because it doesn't have they don't have the receptors to accept it. Okay? So once the hormone has binded to the appropriate receptor, it will have an effect on the cell. And the effect on the cell is totally dependent on what the hormone attaching to the receptor does within the cell itself. Okay, so, and we'll come to many examples of those. So, so as I said before, a target cell, it might just be one gland in the body, or a hormone might affect many organs in the body, since all of those organs have receptors to that hormone. Okay. So at the bottom of the slide, you'll see the example of TSH, which is the hormone secreted by the pituitary gland. And what does it do? It stimulates specifically the thyroid gland to make thyroid hormone, which is T4. Okay? And TSH really doesn't impact other parts of the body very much. It specifically is a hormone that goes to the thyroid gland. There will be many instances of hormones that affect many parts of the body, because many parts of the body have receptors for that particular hormone. So why are we talking about hormones and receptors? What's the purpose in pharmacology? Well, we can have deficiencies in different organs and different systems of hormones, right? So if we have a deficiency, say for example, our thyroid gland isn't functioning anymore, well, that person will need a replacement of thyroid hormone. Or let's say our adrenal gland is diseased and not able to produce cortisol anymore. Well, that patient will need cortisol replacement. Okay, and it goes along like that for many conditions. So if you have a disease where you're not making growth hormone, say, well, we can replace your growth hormone with a synthetic growth hormone. Okay, and the same goes for testosterone, estrogen. So all kinds of hormones in the body can be replaced with hormones that are either synthetically produced or obtained in the laboratory in a different way. So sometimes different disease states will require us to administer a hormone to maintain homeostasis, since the body is unable to make that hormone any longer. Okay. So protein hormones, such as TSH is just a simple protein. It's a protein that stimulates the thyroid gland. So some are proteins, such as TSH or growth hormone, and some are cholesterol-based. And protein-based hormones tend to attach to the cell membrane receptors and have their effect that way. Cholesterol-based hormones go into the cell and have their effect within the cell itself. Okay, so that's just a bit of a difference between cholesterol-based and protein-based hormones. That's all. Now, sometimes we'll use hormones to get a desired effect, and not necessarily because someone's deficient in it. So say I wanted to use cortisol, not because someone has a disease of their adrenal glands and they're low on cortisol, but I want to use cortisol, or say one of its variants, such as prednisone or dexamethasone or hydrocortisone, because I want to suppress the immune system. I want to suppress inflammation. So I could use a hormone in that way, in higher doses to suppress the overall immune system in a whole variety of diseases. Let me give you an example. Someone with active rheumatoid arthritis that has inflamed joints, stiffness, a lot of pain in their joints. We can use a cortisol-based drug to suppress the autoimmune attack on the joints. Okay, so it's not only do we use hormones to replace hormones that are deficient in the body, but sometimes we'll use them to get an even bigger response, such as cortisol. Okay, and also sometimes we'll use anti-hormones, so drugs that will block hormones from working in the body. And a perfect example of that is tamoxifen. So we spoke about selective estrogen receptor modulators when we were talking about osteoporosis. Well, tamoxifen is one of those. And what does it do on the estrogen receptor of the breast? It blocks it. So if it blocks estrogen from stimulating the breast, it can reduce the incidence of developing breast cancer, and it can also treat certain breast cancers that have estrogen receptors on them. Okay, so we can use higher levels of cortisol as an example, which is a hormone, to get certain effects, and we can also block hormones to have certain effects. Okay, so here's a very important part of the endocrine system. So the hypothalamic pituitary system. Okay, so the hypothalamus is part of the brain, and it actually connects to the pituitary gland. You can see it hanging down there, and this is a very important part where the nervous system communicates with the endocrine system. So the hypothalamus is part of the nervous system. The pituitary gland is very important for the endocrine system. And we break the pituitary gland up into two lobes. The anterior lobe, which makes certain hormones, and the posterior lobe, which stores certain hormones. It doesn't make any. Okay, so when we look at this image, you can see there's a blood supply from the hypothalamus to the anterior pituitary. Okay, so there's a signal through blood from the hypothalamus to the anterior pituitary. But when we look at the posterior pituitary, there is no blood supply from the hypothalamus to the posterior pituitary. There's just nerve bundles. So anything that's stored in the posterior pituitary has been made in the hypothalamus, and it's just stored there waiting for secretion. Whereas in the anterior pituitary, the cells make hormones, and they get secreted into the bloodstream under the direction of the hypothalamus through hormones from the hypothalamus that communicate with the anterior pituitary by blood supply. Okay, so this whole system is called the hypothalamic pituitary axis. Okay, and it'll start to make sense as we talk about the various hormones. Okay, so let's talk about the hypothalamus a bit first. So remember, the hypothalamus is part of the brain. One of its purposes is to communicate with the pituitary gland, which is really a very important gland in the endocrine system. Okay, so we break it into anterior and posterior pituitary. The posterior pituitary really just a storage area for two hormones, antidiuretic hormone and oxytocin. Okay, how do those hormones get to the posterior pituitary? By nerves from the hypothalamus. So they are produced in the hypothalamus and stored in the posterior pituitary. When we look at the anterior pituitary, they make their own hormones, and there's a variety of them. Now, how do they get secreted? Well, the hypothalamus communicates with the anterior pituitary with its own hormones and tells the anterior pituitary to secrete hormones into the bloodstream, into the general bloodstream. So the hypothalamus sends its hormones through a little blood flow system that you can see in this image to the anterior pituitary, and then the anterior pituitary, after being stimulated by those hormones, secrete its own hormones into the bloodstream to have an effect on target organs. So really you could say, well, what's the target organ of the hypothalamus hormones? Well, the anterior pituitary cells. Okay, so the target organ is where does the hormone attach to? Okay, and in this case, it's from the hypothalamus to the anterior pituitary, but we'll see that the anterior pituitary secretes a whole bunch of different hormones that'll have effects around the body. Okay, so that's one of the main purposes of the hypothalamus. What else does it do? Well, it has autonomic nervous system functions. So the hypothalamus is partly responsible for heart rate, for constriction of your arteries, vasoconstriction. It's responsible for digestion, sweating. It controls appetite, thirst, emotions in part. Body temperature comes from the hypothalamus, or is controlled by the hypothalamus. If you remember that in pathophysiology, that the hypothalamus regulates body temperature. Okay, so it has this endocrine function with the pituitary gland, but it also has other functions as well. So it's a pretty small area with very important functions. Okay, so I'm going to make sure that I repeat myself a bit so that it makes, so that if you don't get it in one slide, you'll get it in another. So the hypothalamus is really the link between the nervous system and the endocrine system, because it links to the pituitary gland. Okay, and when it stimulates the pituitary gland, the anterior pituitary, which produces its own hormones, can be released, and it can store hormones in the posterior pituitary. I'm talking about the hypothalamus still. Okay, so the glands from the pituitary are released into the bloodstream, and they go all over the body, but they're only going to have an effect where the target receptors are. So it just depends on where the target receptors are. Okay, and wherever the target receptors are, we'll call those the target organs, and it will elicit a certain response in them. Okay, so if we look at the image on the right, the anterior pituitary is going to send a hormone to the thyroid gland to stimulate the thyroid gland. It's going to send a hormone to the adrenal gland to stimulate that. It's going to send a hormone to the ovaries and the testicles to stimulate them, and we'll come to the specific hormones that do that. The pancreas really is not part of the pituitary system at all. It produces insulin and glucagon that are controlled by serum glucose levels. They're not dependent on the pituitary gland. And the parathyroid gland, that's dependent on So the level of parathyroid hormone that's released is dependent on serum calcium levels. Okay? So of all of them in this image, the parathyroids and the pancreas have nothing to do with the pituitary gland. The other ones do, but there's others as well that we'll come to. So really, in effect, the pituitary gland is controlled by the hypothalamus. Okay, the anterior pituitary through hormones that are released by the hypothalamus that go right to the pituitary gland to allow it to release its hormone or to inhibit its hormone release. The posterior pituitary is just a storage place for ADH and oxytocin that's made in the hypothalamus. Okay? The negative feedback loops are really that once hormones are released from the anterior pituitary, once they reach their target organs and cause the target organs to make certain chemicals, they will feed back to the pituitary to turn off further secretion of the hormone. Okay, and that's a way of controlling how much hormone is secreted by the pituitary gland, that there's a negative feedback loop. Let me give you an example. So the anterior pituitary releases FSH and LH, follicle stimulating hormone, luteinizing hormone. Those are responsible for increasing estrogen and progesterone levels in the ovaries. Okay, so once estrogen and progesterone reach a certain level, in a negative feedback loop, they actually, in the bloodstream, they reduce the cells that are releasing FSH and LH. That's called a negative feedback. And that's a way of controlling how much hormone is being secreted. Okay? So, now, could there be a positive feedback loop? Sure, there is an example of that. So say a woman's in labor and she's having regular contractions of her uterus. The cervix is slowly dilating, okay? And the cervix is where the head of the fetus has to come through to make it into the vaginal canal. And as the cervix stretches, it sends a signal back to the hypothalamus and the posterior pituitary to release more oxytocin, saying, I want to be stimulated even more. So as oxytocin is released, the uterus contracts harder and harder, causing more cervical dilation, which then goes back to the pituitary and releases more oxytocin. So that's an example of a positive feedback loop. Okay, so this next slide, we're just looking at, again, the anterior and posterior pituitary, but in a bit more detail. Okay, so the hypothalamus communicates with the anterior pituitary through a blood supply, and the posterior pituitary through a nervous system, through a nerve supply. Okay, what does the anterior pituitary secrete? Well, we just spoke about FSH and LH, and they're responsible for controlling estrogen and testosterone, estrogen and progesterone levels in females, and testosterone levels in males. Okay. Growth hormone is made in a little cluster of cells in the anterior pituitary. Remember, the anterior pituitary is made up of clusters of cells, some of which will produce FSH and LH. Others will produce other hormones. So growth hormone will come from a cluster of cells in the anterior pituitary, which will have an effect on growth of muscle and growth of bone. Prolactin is secreted by the anterior pituitary, which will have an effect on the mammary glands and milk production. Okay. ACTH is adrenocorticotropic hormone. Sorry for the long name, but that is the hormone that stimulates the adrenal cortex to release cortisol into the bloodstream. Thyroid stimulating hormone, TSH, that goes into the bloodstream and stimulates the thyroid gland to make T4. Okay, so T4 is the hormone that is released from the thyroid gland to have its effect around the body. T4, as an example here, will feed back to the pituitary when it's at a proper level in the bloodstream and tell the anterior pituitary to reduce TSH levels because the thyroid hormone is at a good level already. And that's the example of a negative feedback loop. Okay? The posterior pituitary, the storage area, releases oxytocin, again, to help with uterine contractions during labor and also with milk let down in the breasts. Okay? So, for breastfeeding. And as well, it stores antidiuretic hormone, okay, which works on the kidneys to reabsorb water from the kidneys. So it's involved in fluid electrolyte balance. Okay, so hopefully you're getting a bit of an understanding of the pituitary or the hypothalamic pituitary axis. Okay, and here's another image of the hypothalamus and pituitary and the hormones that the anterior pituitary secrete and the hormones that the posterior pituitary secretes. And remember, all these different hormones are being adjusted at different times, right? Because they all have different feedback loops. So try to remember that the anterior pituitary has multiple colonies. One colony of cells will be ACTH producing, another will be TSH producing, and so on. And they have typically different target organs, right? ACTH, the main target cell or organ is the adrenal gland. TSH, the thyroid gland. FSH and LH, the ovaries or the testicles. And the same will go for the posterior pituitary. ADH's target organ is the kidneys. Oxytocin is the breast and the uterus. So just try to get the big picture of the whole system. And the big picture is really all about homeostasis. Maintaining different levels of hormones in the body that then have effects on different target organs to maintain different aspects of homeostasis. That's the whole idea behind hormones and their regulation. So this next slide is just showing you more clearly that the anterior pituitary is really controlled by the hypothalamus with its own hormones. So, for example, FSH and LH is released by the anterior pituitary when the hypothalamus releases GnRH, right? So, gonadotropin releasing hormone, which travels to the anterior pituitary and then stimulates the anterior pituitary to release its hormones, FSH and LH. And what are the target organs? The gonads, the ovaries or the testicles. And what's going to feed back to shut off that system Well, it's either going to be estrogen and progesterone, or in a male, it's going to be testosterone. That's the negative feedback loop concept. Okay? On the right side of this slide, it's showing you that really the hypothalamus is just sending those hormones through the nervous system to be stored in the posterior pituitary and then released from the posterior pituitary, which is ADH and oxytocin. Okay? So the first thing I'd suggest you look at is the image. Look at the size of that pituitary gland. It's tiny, and it's actually accessible through the back of the nose. That's how pituitary surgery is usually performed, through the nose. Okay, because it's the most accessible route to get there. So it's a tiny gland with a lot of functions. Okay, so what kind of disorders can affect the pituitary gland? Well, you can have tumors of different cells in the pituitary gland, and we call those pituitary adenomas. They're not typically malignant, they're not cancerous, they're just overproducing benign tumors. So you could have a benign tumor of growth hormone, that the growth hormone cells that secretes too much growth hormone. You could have overproduction of ACTH, so that will stimulate the adrenal gland too much. You could have a tumor of the cells that produce TSH, and you'd have overstimulation of the thyroid gland. Okay, so tumors can definitely affect the pituitary gland. One of the most common ones is actually a prolactinoma, so a benign tumor producing too much prolactin. And when you produce too much prolactin, you tend to get milk production. So one of the symptoms of a prolactinoma is milk excretion from the breast, whether it's a male or a female. Females often have very irregular cycles from a prolactinoma. It messes with FSH and LH and the cycle with the ovaries. So, but in a male or a female, you could actually have milk production from the breast, okay, and milk secretion. What else can affect the pituitary gland or the hypothalamus? Well, brain surgery can harm that area. Radiation to the brain, say for a brain cancer. If someone's had a history of meningitis, which is an infection of the layers surrounding the brain, the meninges, or an infection of the brain, encephalitis. You could have had a head injury earlier in life that now has injured the pituitary gland. You could have an infarction, which is loss of blood supply to the pituitary gland, resulting in some of the cells dying and not able to produce hormones anymore. You could have a hemorrhage in the pituitary gland with the same effect, unable to produce hormones. So these are all different ways that the pituitary gland can be injured. Okay? Now the next few slides are just explaining what the hypothalamus secretes, where does it act, and then what does the pituitary gland hormone act on, and what's its principal function. Okay, so let's just choose the top one. So when we're talking about controlling the adrenal gland, there's a hormone in the hypothalamus called CRH, corticotropin releasing hormone. Well, that travels to the pituitary, very short distance, and stimulates ACTH to be secreted. ACTH goes into the bloodstream, stimulates the adrenal cortex, which then releases cortisol into the bloodstream to have its effect on a variety of cells. So cortisol is actually the end result of all of this entire system. And cortisol affects so many cells in the body to have its effect. Okay, and we'll talk about that when we talk about the specific diseases that are related to the adrenal gland. Okay, so look at these slides that way, and it'll just help you understand, well, okay, what hormone from the pituitary gland is having an effect on which target organ. On this slide, let's use the bottom one as an example. So thyrotropin releasing hormone, TRH, okay, that's in the hypothalamus, that gets released and travels a short distance to stimulate the anterior pituitary to release thyroid stimulating hormone. Thyroid stimulating hormone goes into the bloodstream. Its target organ, where the target receptors are in the thyroid gland, which are called TSH receptors. And when they're stimulated by TSH, they make the thyroid cells release thyroid hormone into the bloodstream. And thyroid hormone, again, has a variety of effects because there are so many receptors in the body for thyroid hormone. The thyroid gland is almost like the metabolic factory of the body. It controls energy levels, and we'll get to that when we're talking about the diseases of the thyroid gland. Okay, and this next slide, again, get the big picture first, that this is all about maintaining homeostasis. Okay, so antidiuretic hormone is released by the posterior pituitary, made in the hypothalamus, but once it goes into the bloodstream, its target organ with receptors for it are in the kidneys. And when they're stimulated by antidiuretic hormone, they increase water absorption from the collecting ducts. So this will maintain fluid balance in the body, right? So if the bloodstream is has very high levels of electrolytes such as sodium, ADH will get secreted by the posterior pituitary to reabsorb water and then dilute the high concentration or the high osmolarity of the blood to keep all the electrolytes at certain levels, so they're not too high and they're not too low. Okay, so again, homeostasis comes in. And antidiuretic hormone, if I was to say what does it do, it maintains fluid balance in the body. Okay, here are examples of two hormones that are released by the pancreas. So insulin, well, how is insulin released? Well, insulin is released by the pancreas in the setting of high glucose levels in the bloodstream. And what does it do? It acts on pretty well every tissue in the body to move glucose from the bloodstream into the cells to use as energy. Okay? It also stimulates glucose to go into the liver to be stored as glycogen, because the body is saying, there's too much glucose in the bloodstream. After this meal you ate, I'm going to release insulin to move the glucose into the cells, to move it into the liver for glycogen storage that can be used at a different time to turn back into glucose if it's needed. Okay. What's going to turn off insulin secretion? Well, when the serum glucose goes to normal, it's not going to release insulin anymore. What about glucagon? It's just the opposite. right? So glucagon is released when there's hypoglycemia. And the body says, I don't like this. The sugar is too low in the bloodstream. Release glucagon from the pancreas. Glucagon then goes to the liver and tells the liver to break down glycogen to glucose to increase glucose levels in the bloodstream. So it's all about maintaining glucose in the bloodstream. Glucagon's also going to tell fat cells to break down and produce glucose. It's also going to tell the liver to take the protein that it's producing or that it has and convert that to glucose. So it's really another way of controlling glucose balance very closely in the bloodstream. And why would we care about having your serum glucose very tightly controlled? Well, the brain basically uses glucose as its only food source. So the brain doesn't want you to have low glucose levels. And it doesn't want you to have high glucose levels. So it uses insulin and glucagon to really tightly control serum glucose. Okay, on this slide, let's look at the middle one, aldosterone. So aldosterone is also made in the adrenal cortex, but it's controlled and regulated by blood volume and low blood pressure in the kidney. So if the kidney senses low blood volume, such as in dehydration, or hypotension, such as in hemorrhaging, it's going to release aldosterone into the bloodstream. Okay, what's aldosterone going to do? Well, aldosterone is going to promote reabsorption of salt, of sodium, and water is going to also follow it. So sodium and water are going to be reabsorbed into the body. So aldosterone is also involved in maintaining fluid balance. I mentioned ADH. Well, here's aldosterone, also part of regulation of blood volume and blood pressure. Okay. The parathyroid hormone we spoke a bit about already. Thyroid hormone we've spoken about, and we'll speak about it even more once we get to the disease states. Okay, so when we're looking at this slide, we're looking at disorders now. So for example, adrenal cortex, it produces and releases corticosteroids and aldosterone, but we're going to talk about corticosteroids here. And if the adrenal cortex is diseased and not functioning, it's going to undersecrete corticosteroids in a condition called Addison's disease. If it oversecretes corticosteroids in a particular disease state, where it's just making too much corticosteroids, we call it Cushing's syndrome. Okay. Let's look at the hyposecretion of the gonads. So if you're undersecreting estrogen and progesterone, you're basically menopausal if you're not making either one of those. Or if you're underproducing estrogen and progesterone, you're going to have very irregular cycles. So you'll have dysfunctional menstrual cycles. You'll have infertility because you're not making enough to maintain normal hormone cycles for your periods. Okay. If you undersecrete testosterone, you will have the male will have significant changes in the body because all the cells that were being maintained by testosterone won't be stimulated by testosterone anymore. And you can see on the far right that we can use drugs to replace the hormones depending on the condition. So in Addison's disease, for example, we can replace the corticosteroid, say with hydrocortisone or with prednisone. With Cushing's syndrome, which is overproduction, it depends on what the overproduction of corticosteroids is occurring from. If it's a tumor in the pituitary gland, so an ACTH producing tumor, well, that can be treated with surgery to remove the tumor. Okay? Or sometimes it can be treated with drugs, such as ketoconazole and another one, mitotane. I wouldn't spend too much time knowing those, but they actually block corticosteroids from working properly. So you're not addressing the oversecretion, but you're actually addressing the end effect of the corticosteroids with those drugs. Okay? So the drug therapies will just depend on what disease state we're talking about. Okay, so again, well, let's talk a bit about some of these. So the posterior pituitary secretes ADH, antidiuretic hormone. If something happens to the posterior pituitary, a disease process or an injury or a surgery injured it, and you're not producing antidiuretic hormone, then you have a condition called diabetes insipidus. What's going to happen? You're unable to reabsorb water and fluid in the collecting ducts, and you're going to have incredible amounts of urine and electrolyte disturbances that we'll get to. How do we treat it? We can replace antidiuretic hormone with a drug that basically has the identical action called desmopressin or vasopressin. Okay, so it's just a direct replacement. Hypersecretion of ADH, so a condition where you're making too much ADH is going to cause incredible amounts of reabsorption of fluid in the collecting ducts. So volume overloaded. And there's drugs. I wouldn't spend too much time memorizing those drugs because they're not frequent drugs, but these are just giving you an example right there of drugs that can be used to inhibit the action of ADH in the setting of hypersecretion. Okay? Growth hormone, well, in children that will be called dwarfism. If you hyposecrete it from the anterior pituitary, and we can replace that with growth hormone, and the name for growth hormone is somatotropin. So somato is body, tropin is growth. So it's a synthetic growth hormone that we can replace the deficiency with. If you hypersecrete growth hormone, and this is typically from a adenoma on the pituitary gland that's over-secreting growth hormone. If it's in children, you get gigantism because their growth plates haven't closed yet. So the bones grow faster and faster and bigger and bigger. So you end up with a condition called gigantism. In adults, your growth plates have closed. So the bones aren't going to get longer. But you get a very specific condition called acromegaly. And because growth hormone affects so many parts of the body, you get very specific changes with acromegaly that we'll talk about. How can we treat acromegaly? Well, there's a drug that inhibits growth hormone secretion called octreotide. So it inhibits growth hormone secretion. Okay, so that can be a treatment either in children with gigantism or in adults with acromegaly. Okay, so let's go on to another slide. So I'm just giving examples from each slide. So let's concentrate on the anterior pituitary diseases a bit. And the ones we're going to concentrate on are growth hormone excess or growth hormone deficiency, thyroid hormone excess or thyroid hormone deficiency, and lastly, adrenal hormone excess or deficiency. Okay, and they all have different names, right? Too much growth hormone, gigantism in a child, acromegaly in an adult. Too little growth hormone, dwarfism. Okay, in children, and because it remains that way, they have poor growth, very small stature, and we call it dwarfism. Thyroid hormone excess is going to be hyperthyroidism. Thyroid hormone deficiency, hypothyroidism. Adrenal hormone excess, Cushing's disease. Adrenal hormone deficiency, Addison's disease. Okay, so growth hormone. The other name for growth hormone is somatotropin. And normally, somatotropin, or growth hormone, is produced and secreted in the anterior pituitary. And it's what's called an anabolic hormone, meaning it's tissue building, right? It promotes the growth of bones and many other tissues around the body, including muscles. So it's going to increase the length and the width of the bone. It's going to stimulate skin and connective tissue growth. And it's going to increase metabolism of the body because the body is so busy growing, right? So it's going to enhance the uptake of amino acids. It's going to increase the protein synthesis from those amino acids. And it's really a body building hormone, okay, in particular for muscles and for cartilage and for bone. So that's how I would think of growth hormone. Okay, so what happens if you have a deficiency of growth hormone in children? The cells in the anterior pituitary just don't make growth hormone. Well, this results in dwarfism. Okay, so, and this is partly why we follow children's growth rate from birth. We follow their height, their weight, and their head circumference. And the reason why we follow these parameters is to see that they're following a certain growth chart. We want to know that they have normal growth as they go on in years. And if they don't, then we may suspect certain conditions are occurring because their growth is either accelerated or underperforming. Okay? And definitely in growth hormone deficiency, they'll be very, very short for their age. So under the 5th percentile for age and gender, right? So measuring a child's growth, height, weight, head circumference is very important to potentially diagnosing a growth issue. Okay. And what can we do for dwarfism once we've picked it up, say through noticing on a growth chart, or the parents notice that the child just isn't growing very well? We can use a synthetic growth hormone. Now remember, most of these are proteins, so they can't be taken by mouth. If you take a protein by mouth, it just breaks down in the stomach, right, because of the acid. So most of these are going to be injectable. So there's synthetic somatostatin. Okay? And typically this will be a lifelong treatment because the anterior pituitary is just not making any growth hormone. Now, will this completely correct their height and their growth? No. But it's definitely going to improve it, right? So because there's been a time where they didn't have any growth hormone, well, they've lost that part with the growth hormone deficiency until it's diagnosed and growth hormone injections begin. Okay, and here in this image we're seeing undersecretion of growth hormone in childhood called pituitary dwarfism, and oversecretion of growth hormone in childhood, which results in gigantism. Okay, and it's different if you develop growth hormone excess as an adult, because that will result in acromegaly. Because remember, your bones have fused, you're not going to become a giant. You're not going to grow and grow and grow. But they get other very specific changes. They get much more soft connective tissue growth. They get coarse features of their body in acromegaly. So maybe Google acromegaly images and you'll see that they have specific changes that occur with acromegaly. Okay, on this prototype slide, somatotropin, which is growth hormone. And growth hormone, its main indication would be for growth hormone deficiency, whether it's in well, typically it'll be in dwarfism, right? And continue throughout life. It can also be used to stimulate growth in other more general conditions, such as just poor growth in children, or in a condition called Turner syndrome, where a female only has one X chromosome, and typically they have stunted growth. Okay, but in general, it's growth hormone replacement. Now, how is this given? So the only way it can be given is intramuscularly or subcutaneously, since, again, it's a protein. And since it's a protein, it cannot be taken by mouth. Okay? What are the complications of someone receiving growth hormone, or the adverse effects? Well, this is an anabolic hormone, meaning it's going to stimulate growth, right? So catabolic means breakdown, anabolic means growth. And this is definitely an anabolic hormone. So whenever the body is trying to grow, it's going to stimulate increased sugars, increased glucose in the bloodstream. So it's going to break down glycogen and cause hyperglycemia. Okay? So now, what's hyperglycemia going to cause in terms of symptoms? Well, if you have very high sugar levels, and we'll talk about diabetes much more, but very high glucose levels in the bloodstream are going to make you urinate more. They're going to make you thirsty, and they're going to make you hungry. Okay? So we'll talk about that further. But typically these patients will need to be monitored for developing of diabetes or hyperglycemia, which is basically the same thing. So the other electrolyte they can elevate is calcium. So these patients will be more at risk for developing kidney stones, since most kidney stones are from calcium stones. Okay, you can get uric acid stones in a condition called, in a condition where you have elevated levels of uric acid, which can also lead to gout, you can make uric acid stones. But for somatotropin, since we're talking about it here, high sugar levels, high calcium levels. Okay? We typically try to avoid this in someone who's severely obese or has sleep apnea, since it can cause it stimulates tissue growth, right? So it's going to aggravate obesity. It's going to aggravate sleep apnea, where when you go to sleep, you have periods where you're apneic, you're actually not breathing, and it's typically from obstruction from the extra tissue you have, say, in your larynx. Okay, so patients that are overweight can often have sleep apnea. That's not to say that you have to be overweight to have sleep apnea. You can still have that condition. Some conditions aggravate sleep apnea, such as sedatives or alcohol. They relax the back of your throat muscles even further, leading to more sleep apnea. Okay? So now when we're talking about somatotropin, we're going to want to monitor growth, right? So height and weight, and the overall pattern of growth of the child while they're receiving this medication. Okay, so the other thing to consider with this medication is rotation of injection sites. And that if it's abdominal injections subcutaneously, or thigh injections, and often it's subcutaneously there as well. Can be given intramuscularly sometimes. Okay, so just see this as growth hormone replacement. So we've spoken about this already, gigantism, and this is excessive growth hormone. And how are you going to get excessive growth hormone in a child? It's typically from a pituitary adenoma that's secreting too much growth hormone into the bloodstream. Okay? And with excessive growth hormone, you'll develop gigantism as a child. And this is typically treated with surgery, which is transsphenoidal, meaning through the nose, to access, so they go to the back of the nose. They have to go through a bone at the back of the nose and then access the pituitary gland and remove the section that has the adenoma in it. Okay? So it doesn't require the skull to be opened or anything like that. It's all done through the nose. Acromegaly, again, excessive growth hormone development, typically a pituitary adenoma, and the growth plates are closed, so the bones can't continue to grow in length, but it leads to excessive tissue deposition all over the body. Okay, and these patients often develop bone deformities, arthritis from all the growth hormone they have circulating, and typically they die prematurely from heart failure, from the stimulation of the growth hormone that they've had for years. Now, the treatment for acromegaly is typically surgery as well, to remove the pituitary adenoma. If that's not possible, radiation can be used, and as well some of the medications that were in one of those slides above in terms of blocking the effects of growth hormone. Octreotide is the medication that can be used for this. Okay, so here's a hormone called octreotide that we just mentioned, and it inhibits release of growth hormone, right? So in gigantism in children or acromegaly, it can be part of the treatment to reduce growth hormone levels, okay? We also use it in another condition, and you'll likely hear about this in another semester, for bleeding esophageal varices. We're not going to concentrate on this in this module, but when you have cirrhosis of the liver, the veins that are returning to the liver from the intestines, called the portal vein, which is a huge vein that returns all the nutrients and food that you've eaten, and it gets processed in the liver. Well, when you have cirrhosis, all those veins are backed up, because cirrhosis means fibrosis and scarring of the liver. And the veins can't flow through the liver anymore. So all the veins back up to the intestines and they get dilated. And you can develop very distended and enlarged veins in the esophagus called esophageal varices. And you can get stomach varices as well, these dilated abnormal veins in the setting of cirrhosis. And if they start to bleed, they bleed and bleed and bleed tremendously. And often a surgeon will have to go in and stop the bleeding. But we'll also try this medication called octreotide, which tries to vasodilate and help the flow in the portal vein system to reduce the bleeding. Okay. So the action of octreotide, when we're talking about in this module, is to limit the release of growth hormone. Okay. It also has an effect of inhibiting insulin and glucagon secretion in the pancreas, but that's not a huge action. I would concentrate more on the fact that it limits growth hormone release. And in bleeding esophageal varices, as I said, it reduces portal vein blood pressure, trying to allow more flow to get away from the intestines and stopping the bleeding. Okay, what are the adverse effects of octreotide? Often gastrointestinal symptoms, and because you've altered regulation of insulin and glucagon, you can get hypo and hyperglycemia. Okay, so someone who's receiving octreotide for acromegaly or gigantism, their sugars will be monitored to make sure that they're not getting too high or too low. Okay, and octreotide is, again, injected intramuscularly. It's a protein, so it needs to not be given orally. Okay, so we're still in the anterior pituitary, right? We spoke about growth hormone a bit, and now we're going to go on to thyroid hormone. Now, thyroid hormone can be overproduced in the thyroid gland in a condition called Graves' disease, which is an autoimmune disease where you develop antibodies that stimulate the TSH receptors. And by doing that, it stimulates the thyroid gland to produce more and more thyroid hormone. The opposite is thyroid hormone deficiency, and again, the most common cause of that is an autoimmune disease called Hashimoto's thyroiditis. And those are those are antibodies that destroy the thyroid gland. Okay? So you have hyperthyroidism that has antibodies that stimulate the TSH receptors, making tremendous amounts of thyroid hormone. And then you have Hashimoto's thyroiditis, that you have antibodies that destroy the thyroid gland, leading to hypothyroidism. Okay? So when we're talking about hypothyroidism, we're referring to reduced production of typically T4. Okay, so T4 is by far the most common hormone released by the thyroid gland. And hypothyroidism is typically caused by loss of thyroid gland function, right? Hashimoto's thyroiditis, destruction, autoimmune destruction of the thyroid gland. Okay. Now, what's a much, much less common disease that could cause your thyroid not to function? Well, what if you have a disease of the pituitary gland and you can't make TSH? Well, then you're going to have a condition where you don't make enough TSH, the TSH doesn't get into the bloodstream, it doesn't stimulate the thyroid gland, and it leads to hypothyroidism. Okay? That would be called secondary hypothyroidism, meaning the pituitary gland is the cause of the hypothyroidism. That's much, much less common than Hashimoto's thyroiditis, which is primary hypothyroidism, meaning the thyroid gland itself has the disease. Okay? Now, typically, under normal circumstances, your T4 that you have circulating in your bloodstream is secreted into the bloodstream. Is secreted into the bloodstream by the thyroid, and has actions all over the body that we'll get to. But it also feeds back to the pituitary gland and turns off secretion of TSH. And that's how the whole cycle is regulated. So as T4 or thyroid hormone goes up in the bloodstream, it feeds back in a negative way to the pituitary gland and reduces TSH levels. So we can actually monitor TSH levels when someone is receiving thyroid hormone to see that we're not giving too much thyroid hormone. If we're giving too much thyroid hormone as a replacement in hypothyroidism, TSH levels will be extremely low because it'll be so suppressed by the thyroid hormone. If we're giving too little thyroid hormone, the TSH from the pituitary will be elevated because the pituitary gland is saying, well, there's not enough thyroid hormone in the bloodstream, I'm going to release more TSH. So typically we monitor the thyroid gland when we're giving thyroid hormone with blood tests that are typically TSH, and sometimes we'll even get a thyroid hormone level called a free T4 in the bloodstream. Okay? So hypothyroidism is much, much more common in females, and it often runs in families. So your sister had it, or your mother had it, or your grandmother had it. Very common in females compared to males. Okay? Hyperthyroidism is elevated levels of thyroid hormone. And by far the most common cause is a condition called Graves' disease, an autoimmune stimulation of the TSH receptors, leading to elevated thyroid hormone. And what happens there is the thyroid hormone feeds back to the pituitary gland and reduces TSH. Okay? And so what would we expect if we saw someone with Graves' disease? Well, they often have bulging eyes, so it's called proptosis, where your eyes are sticking out. They often have heat intolerance because the factory is turned on so much. The thyroid gland is releasing so much thyroid hormone. They can have hypertension, tachycardia, because everything's being activated. They often lose weight because of all the metabolism that's occurring. So if we were to check someone's blood who we suspected would have hyperthyroidism, they would have an elevated T4 level and a very suppressed TSH level. If we suspected someone had hypothyroidism, when we did some blood tests, we would expect low T4 levels, low thyroid hormone levels, and elevated TSH levels. And the TSH is trying very hard to stimulate the thyroid gland to release more thyroid hormone, but because of Hashimoto's thyroiditis, it's unable to produce more thyroid hormone. Okay, so this slide is showing you the differences in symptoms of hypothyroidism versus hyperthyroidism. Hypothyroidism, the most common cause being Hashimoto's thyroiditis, in particular in women. Okay, so let's just go through a couple of symptoms though. What's the enlarged thyroid gland from? Well, the pituitary gland is secreting so much TSH, and it's stimulating this thyroid gland to produce thyroid hormone, but it's not. And because it's being stimulated so much, the thyroid gland actually enlarges. And that's called a goiter. When you have an enlargement of a thyroid gland, we call it a goiter. Okay, so because you have low thyroid hormones in your bloodstream, you have a slow heartbeat, you have a poor appetite, you have irregular menstrual cycles, because thyroid is important in regulation of menstrual cycles. So it's not only estrogen and progesterone. Background thyroid levels need to be normal in order to have normal menstruation and normal fertility. You tend to accumulate more tissue and weight gain in hypothyroidism. So you can get nerves that can become blocked in the wrist because of all the excess tissue, and we call that carpal tunnel syndrome. You tend to be intolerant to the cold because the thyroid gland just isn't working. The factory isn't working. So you're intolerant to cold weather. You have poor memory. You're tired all the time. You're constipated because the thyroid hormone is responsible for keeping so many organs active. You tend to have cold skin, cold extremities, some weight gain, puffy face, dry skin, and hair loss is a common symptom in hypothyroidism. So I guess I went through all the symptoms. Sorry about that. My intention was just to go through a few. Let's go to the other side, hyperthyroidism. So that would be Graves' disease. You tend to have proptosis, bulging eyes. You can have an enlarged thyroid gland. Why? Because the thyroid gland is being stimulated by autoantibodies that are stimulating the TSH receptors. You can be tachycardic, fast heart rates, everything's being turned on, increased appetite, weight loss. Again, your periods can be irregular. You can be tremulous, shaky from all of this thyroid hormone that's in your bloodstream. Hyperactive, irritable. You can have high blood sugar because the thyroid hormone is activating the whole system. You're intolerant to heat. Okay? You're sweaty. And finally, you can also have brittle hair. But hair loss, I would say, is more common in hypothyroidism, but it can also occur in hyperthyroidism. So I would look for the differences. There are a couple that are similar, like the hair loss, but that would be the exception. Most of them are quite different symptoms. Okay, so we don't have to spend much time on this slide. Hypothyroidism, by far the most common cause, Hashimoto's thyroiditis. Autoimmune destruction of the thyroid gland. By far more common in women. I can't think of the last time I saw a male with Hashimoto's thyroiditis leading to hypothyroidism, but I see females all the time with this condition. Okay, so most of the time you're going to see women on replacement hormone, or sorry, replacement thyroid hormone for Hashimoto's thyroiditis. Okay, and the symptoms we've gone over, but here are just the common ones: the weakness, the fatigue, the weight gain, the cold intolerance. Everything's kind of shut down a bit. The factory's not working. Lethargy, slow reflexes when they're checked, mental dullness. Okay, so the slide above will give you more, but those are the general symptoms of hypothyroidism. Now, when we're talking about hypothyroidism, another term for it is myxedema. And the reason why myxedema is a term is because in hypothyroidism you get coarse skin, dry, flaky skin, and some swelling, some edema. So we called it myxedema. It's just another term for hypothyroidism. And if hypothyroidism is severe, meaning you have very little thyroid hormone circulating in your bloodstream, you can develop myxedema coma, where your level of consciousness is reduced. You're not just lethargic anymore. You've become semi-comatose or unconscious because you're so deficient in thyroid hormone. Okay, so myxedema is really hypothyroidism. Myxedema coma is just really, really severe hypothyroidism. Cretinism is an infant that's born with congenital hypothyroidism. So they have a deficiency of thyroid hormone at birth. And they have abnormal mental development, abnormal growth. And really, this is the reason why all newborns get a TSH checked before discharge in hospital, right? So a newborn will get a TSH and they'll be checked for PKU, which is an inherited amino acid disease, so phenylketonuria. Those two tests will be done with a heel prick, typically, as a blood test prior to hospital discharge. And the reason why those two are checked is because they're very easy fixes. Hypothyroidism can be easily addressed by just giving the replacement hormone as a pill. Okay, so if it's such an easy fix, then it's definitely checked for. If there was no cure for it, we probably wouldn't do the blood test because there's nothing we can do about it anyways. But because it has dramatic effects if we miss it, and it's a very easy replacement hormone to give, infants get a TSH. Okay, so let's talk about the pharmacotherapy for hypothyroidism. And remember, the most common cause of hypothyroidism, Hashimoto's thyroiditis, which is an autoimmune destruction of the thyroid gland. And typically the replacement is with a medication called levothyroxine, T4. Sometimes, and much less commonly, T3 needs to be added. But that's a pretty rare instance. So most of the time it's just levothyroxine. And it's a lifelong treatment. With Hashimoto's thyroiditis, it's not like the thyroid is going to start functioning again. So patients are on levothyroxine for life. And they're monitored for life. to make sure that their thyroid hormone is at the proper level. So when we're starting levothyroxine, the saying start low and go slow, meaning we start at a low dose and we gradually increase the dose until they're at a proper dose. And the reason for that is to avoid the sudden overstimulation of the body from full dose levothyroxine. So it's a gradual process. I'll give you an example. If we just started full dose levothyroxine in an older patient, we could cause them to have tachycardia, angina. We could put them into arrhythmias, such as atrial fibrillation, because we've given them a sudden full dose of the thyroid replacement. So how do we monitor the dose of levothyroxine that someone will need? Because everyone may need a slightly different dose. We typically know the approximate dose of where patients will end up with, but different people require different doses. And we monitor the dose that a patient needs with a serum TSH. So if you remember, TSH is made from the pituitary gland, and it's very elevated when you have hypothyroidism, because it's trying to stimulate the thyroid gland to make the hormone that it can no longer produce. So when we start giving someone levothyroxine, the TSH will gradually start to drop, right? Because there's that feedback loop. And once the TSH is at a proper level, it's within a normal level that we would expect if someone were to have proper thyroid hormone levels, then that's typically where we leave the dose. Sometimes we can actually check a free T4 level. So that's a blood test where we're directly checking the thyroid level in the blood. Most of the time, we'll just do a TSH, which gives us a very accurate idea that the pituitary is producing the proper amount of TSH, and the negative feedback loop is keeping the TSH at a proper level because the patient's at the right dose. Okay, so most of the time it's TSH. It's often every 6 to 12 months that patients will have their TSH levels drawn. But if we really want to see what the T4 level is in the bloodstream, we'll do a free T4 level. Okay, and so here's the prototype slide on levothyroxine, or the brand name Eltroxin. And really all of these under the indications are different conditions of hypothyroidism. So the first one, hypothyroidism, you could think that, okay, the most common way to become hypothyroid is Hashimoto's thyroiditis. Myxedema coma, as I mentioned before, is really a severe deficiency of thyroid hormone, and the patient is semi-comatose, or even worse, they're in a coma. Okay, so that's just severe hypothyroidism. Cretinism is congenital hypothyroidism. The infant is born with a deficient or a poorly functioning thyroid gland. They need levothyroxine. Post-thyroid surgery, well, you'll need levothyroxine there. If your thyroid gland is being removed, you'll need thyroid hormone replacement. Radiation to the thyroid gland can damage the thyroid gland, and patients will often need replacement with levothyroxine there. Okay. Now, you'll see the term goiter there, and goiter just means an enlarged thyroid gland. So why would a thyroid gland be enlarged? Well, What if you have Hashimoto's thyroiditis and the pituitary gland is making tremendous amounts of TSH to try and force the thyroid gland to make thyroid hormone? Well, the thyroid gland will become swollen because it's being stimulated so much, and patients will have a swelling in their neck where the thyroid gland is. Okay? The opposite can happen as well. Someone with Graves' disease, where their TSH receptors are being overstimulated and they're making tremendous amounts of thyroid hormone, they can also have a goiter as well. Okay, so a goiter doesn't mean that you have low thyroid hormones in the bloodstream or high thyroid hormones. It just means your thyroid gland is swollen, and it can happen in either scenario. Okay, so really this is a synthetic form of thyroid hormone that the body used to make. Okay, adverse effects. Well, definitely if we're giving too much of a dose, it will lead to hyperthyroidism. And you can see on one of the above slides the symptoms of hyperthyroidism. And all we need to do in that case is reduce the dose. And how do we know someone is hyperthyroid? Well, sometimes just clinically, patients will come in and say that they're heat intolerant, they have palpitations, they have racing heart, or just based on a blood test, a TSH. And if the TSH is very, very low, we know that we're giving too much levothyroxine. Okay. Another adverse effect that's important to remember is too much circulating thyroid hormone that we're giving to a patient leads to thinning of the bones, osteoporosis. Okay. So thyroid hormone directly thins the bones. And that's why we're careful with monitoring thyroid hormone so that we don't cause osteoporosis, which can be somewhat difficult to reverse. Atrial fibrillation, I mentioned, if you're overstimulated with too much thyroid hormone, atrial fibrillation is a common arrhythmia that patients can develop. So another reason to monitor their TSH. So contraindications, thyrotoxicosis just means you basically just have a condition where you're making too much thyroid hormone, and that would be something like Graves' disease. In the setting of someone who has coronary artery disease, angina, or has had a heart attack, it's not purely a contraindication. It would be a reason to start very slowly if they needed a thyroid replacement, and to gradually increase the dose. Okay. And the same would go with adrenal insufficiency. So the adrenal gland makes cortisone, and without cortisone, your body is not able to cope with stress as much. Okay, so by giving them levothyroxine, it's going to be a bit of a stress on the body. So someone who has a disease of the adrenal gland where they don't make enough cortisol, and then suddenly starting them on levothyroxine can be an issue. Okay, so under nursing considerations with levothyroxine, yes, we're careful with the dose. We go up slowly. We monitor them for any cardiovascular issues because the thyroid hormone is stimulating. We monitor the TSH and the T4 levels in the bloodstream to make sure that they're at the proper dose. Often in pregnancy, you may need a higher dose. So women that are pregnant will get their TSH checked if they're on levothyroxine. And definitely starting low and going slow in the dose when you're initially starting levothyroxine. And patients are definitely advised never to abruptly stop this medication because their thyroid hormone will drop very, very quickly It's typically a once-a-day dose, so they will develop symptoms of hypothyroidism very quickly if they stop it abruptly. Okay, so let's talk about hyperthyroidism. The most common cause being Graves' disease, an autoimmune disease that antibodies attach to the TSH receptors in the thyroid gland and produce tremendous amounts of thyroid hormone. You can also be hyperthyroid from receiving too much levothyroxine, for example, and that's why we monitor patients that are on levothyroxine. And these are some of the common symptoms of hyperthyroidism. So T4 is a stimulating hormone. You can think of it as the factory of the body that's stimulating cells around the body. So excessive sweating, heat intolerance, because the factory is working on overload. You're tremulous, nervous, agitated. You can have a fast heart rate. You can have atrial fibrillation. You could be losing weight from hyperthyroidism. Difficulty concentrating because it's an activating hormone. And women often have irregular cycles. So someone who comes in and has developed irregular menstrual cycles when they were regular previously, we will check a TSH to see if there's something wrong with their thyroid gland. Okay, so the next slide, the most common cause of a disease state that leads to hyperthyroidism is Graves' disease. And these patients typically have high circulating T4, and they have low TSH levels because the pituitary gland has been turned off by that negative feedback loop from the T4. So these are symptoms that patients often have with Graves' disease. So exophthalmos just means that their eyes bulge out a bit, and that's because they develop soft tissue behind the eyeball with this disease, and so it moves the eyes forward a bit, so they get bulging, buggy eyes. Okay, the goiter is what I mentioned before. Because of that overstimulation of the thyroid gland, it swells up. Arrhythmias and tachycardia because of the stimulating nature of T4. Nausea and diarrhea can happen because the T4 is stimulating the intestines. The irregular cycles in women, very common for women to have irregular cycles when they have abnormal T4 levels where they're elevated. Tremulous, shaky, they can have a lot of nervousness, weight loss, sweating. I mentioned heat intolerance before. So all of the things that you can think of that are happening when you have an excessive T4 level, which is a stimulating type hormone. Okay? Okay, so we come to a prototype medication, methimazole, and there'll be another one after this slide. So this is one of a few medications that we can use to turn off the thyroid gland, to stop production of thyroid hormones. Okay, so any condition where you have excessive thyroid hormone production, we can use methimazole. Graves' disease will be the most common, and we can also use this medication just to reduce the thyroid hormone level prior to thyroid surgery. Okay, so say someone has a thyroid cancer that's producing tremendous amounts of thyroid hormone. We could use this drug to stop the thyroid from producing that much thyroid hormone, and then they're going to go and have surgery to remove the thyroid gland. Okay, so really that's the function of it. It stops iodine from being activated in the thyroid gland, and you need iodine to make proper thyroid hormone. And that's why goiter and that enlarged thyroid gland is common in other countries that have deficient iodine in their diet. Because the iodine goes to the thyroid gland and it's used to produce proper normal thyroid hormone. Okay, and that is why we have iodine in our salt in North America. Iodine has been added to salt to avoid patients developing a goiter because they can't make proper thyroid hormone. Okay, so now if you give too much methimazole, what could happen? Well, you could overshoot the dose, and that could lead to hypothyroidism. Okay, so how do we monitor that? We would check T4 levels in the bloodstream and a TSH. The other adverse effect of methimazole is bone marrow suppression. So when you see agranulocytosis, that's usually referring to bone marrow suppression and a significant drop in your white blood cell count and your neutrophils. Okay? So we're pretty careful not to use this medication in pregnancy unless someone absolutely has to take it. But there's another choice that we'll talk about. And we would definitely avoid it in anyone who has any form of bone marrow disease. Okay. So under nursing considerations, monitoring the blood levels of thyroid hormone and TSH, monitoring for signs of hypothyroidism, because someone could go from hyperthyroidism to hypothyroidism with this medication. Monitoring the weight, because thyroid hormone regulates your weight. So if you're suddenly gaining weight, that could be an indication that you're now hypothyroid. Okay, and just advising patients that if they have signs of infection, that they really should let their healthcare provider know, because they would likely need a CBC to make sure that their bone marrow is functioning normally. Okay, so let's talk about the other medication that we can use for Graves' disease or hyperthyroidism. And remember, thyrotoxicosis is just another term for I have too much thyroid hormone in my bloodstream, right? So you're toxic with thyroid hormone. So we could call Graves' disease thyrotoxicosis, because that's what they have. They have too much thyroid hormone in their bloodstream. Okay, and again, this inhibits thyroid hormone production. So it directly works on the thyroid gland, just like methimazole. And it has very similar adverse effects. It can cause hypothyroidism, sure, if the dose exceeds what they needed. It can cause some bone marrow suppression, not as much as methimazole, and it can cause a mild hepatitis. It can inflame the liver, so we often have to monitor the liver. Okay, so under nursing considerations, this is typically the one that you're going to see with someone who's pregnant. You'll often see this one used in Graves' disease to reduce the thyroid hormone. And we still monitor for signs of infection because of that bone marrow suppression potential, and also for hypothyroidism. Okay, so I would say this is a very common medication for someone who is being treated for Graves' disease. Okay, so let's move on to this next slide about radioactive iodine. So why would we use radioactive iodine? Well, in low doses, radioactive iodine will be taken up by the thyroid gland, and we can use it for diagnostic purposes to look at the function of the thyroid gland itself. In high doses, it can be used to actually destroy the thyroid gland. So for example, in someone with Graves' disease, radioactive iodine could be used. Or in thyroid cancer, where the radioactive iodine is taken up by the overactive thyroid gland, whether it's Graves' disease or a thyroid cancer, and the tissue, the gland, is destroyed. Okay, so you can imagine that radioactive iodine could take someone from hyperthyroidism to hypothyroidism as an adverse effect. Okay, so really in higher doses, it's used to reduce the function of the thyroid gland. Okay, because it destroys some of the tissue, and because it's radioactive, the iodine has been linked to radioactivity. Where does the iodine typically go? To the thyroid gland. You can still have symptoms from the radiation dose that you received, or potentially bone marrow suppression since it's been injected into you. Okay, so definitely anyone who's pregnant is not going to receive radioactive iodine. And somebody who has received radioactive iodine is going to be advised to avoid close contacts, hugging, say children, just to avoid being in direct close contact with people, because they will have some radioactivity for a period of time. Okay, so really you can think of this medication as a way of destroying or partly destroying the thyroid gland, and often patients become hypothyroid. And then what's the treatment for that? Levothyroxine. Okay, so I don't think this is used as commonly as in the past, but basically you could treat someone with Graves' disease, destroy the thyroid gland, and now they're hypothyroid and they can receive levothyroxine. Okay, typically with Graves' disease you would use methimazole or propylthiouracil, and for thyroid cancer you'd typically have surgery now, and then followed by, since your thyroid gland is missing, that would be followed by replacement levothyroxine. Okay, but it has been used in the past, and you may still see it used now to control hyperthyroidism and to treat thyroid cancer. Okay, so let's move on to the adrenal gland. The adrenal gland is located at the superior poles of your kidneys, so it lives right on top of the kidneys, and there's different layers to the adrenal gland that we'll talk about. So the outer layer is called the adrenal cortex, and the inner portion of the adrenal gland is called the adrenal medulla. So what controls the adrenal cortex? The adrenal cortex is controlled by the pituitary gland, by secretion of ACTH, so adrenocorticotropin hormone. So when the pituitary gland releases ACTH, it travels via the bloodstream and it stimulates production and release of glucocorticoids. Okay, so typically cortisol. Now, what else is produced by the outer part of the adrenal gland in the cortex? Well, you have your what are called mineralocorticoids. That's aldosterone. Okay, and aldosterone has typically a different way of being released and secreted by the adrenal gland, and that's That's with your renin-angiotensin-aldosterone system, right? And then aldosterone works on the renal tubules to reabsorb salt, which then reabsorbs water and excretes or secretes potassium. Okay, so ACTH from the pituitary gland is mainly involved in stimulating the adrenal cortex to release glucocorticoids, which is cortisol. Okay, so what else is made there? Well, you have small amounts of estrogen and also testosterone that are produced there. The adrenal gland isn't the main producer of estrogen and testosterone. Your ovaries are the main producer of estrogen, and the testicles are the main producers of testosterone. Okay, so now let's look into the deeper portion of the adrenal gland, and that's where your catecholamines are produced. And catecholamines we refer to as a group, but really we're talking about epinephrine and norepinephrine. And they're part of the sympathetic nervous system, right? So those are both stimulated to be released by sympathetic stimulation. Okay, so for example, when you're afraid, when you're scared, when you're in danger, the sympathetic nervous system will stimulate the adrenal gland to release epinephrine and norepinephrine for a fight or flight response. Okay, so it goes directly into the bloodstream. So basically, the inner shell, epinephrine and norepinephrine. The outer shell, the cortex, is where you have your glucocorticoids, a bit of estrogen and testosterone, and also your aldosterone, which is responsible for fluid balance, reabsorption of sodium and water. Okay? And remember, there's a negative feedback loop here for the glucocorticoids. So when cortisol is released into the bloodstream, it goes through the entire bloodstream, and part of it goes to the pituitary gland, and it down-regulates, it shuts off the cells that are producing ACTH, okay? And that's how it stays at proper levels in the bloodstream, by turning off ACTH when it's at a proper serum level, okay? And we'll talk about cortisol in a minute, because cortisol has a lot of functions in the body. Okay, so let's discuss Cushing's syndrome. And Cushing's syndrome is really any condition that leads to excessive glucocorticoids or cortisol in your bloodstream. Okay, and the most common cause of Cushing's syndrome is patients that have been prescribed glucocorticoids for other conditions. So, for example, someone who's taking prednisone long-term for lupus or for rheumatoid arthritis. So the most common way of developing Cushing's syndrome is iatrogenic, meaning it's been caused by a medical treatment. Okay? How else can you develop Cushing's syndrome? Well, you could have a tumor in your pituitary gland that's producing too much ACTH. And the tumors in the pituitary gland are usually benign, so we call them benign pituitary adenomas. And whether they're secreting too much ACTH, or they're producing too much growth hormone, or they're producing TSH, will determine what kind of adenoma it is. So if we have an ACTH producing adenoma in the pituitary gland, that's going to lead to overstimulation of the adrenal cortex and oversecretion of cortisol into the bloodstream. And that particular scenario It's called Cushing's disease. Okay, so anything that's causing you to have too much cortisol in the bloodstream on a long-term basis is Cushing's syndrome. But we've reserved Cushing's disease for a pituitary tumor that's making too much ACTH. Okay? What else could make too much cortisol in the bloodstream? Well, you could have an adrenal tumor in the cortex, and that adrenal tumor is producing too much cortisol and secreting it into the bloodstream. Okay? So pituitary tumors can cause it, adrenal tumors can cause too much cortisol, but by far the most common cause is the medical community that has had to treat patients with glucocorticoids for other diseases, and they've developed Cushing's syndrome. Okay? And if you look on the right here at the slide, these are common changes when you have too much cortisol in your bloodstream. So and we see this when we give patients prednisone or dexamethasone or hydrocortisone. And we would also see it in a patient that's overproducing cortisol because of a disease state they have, such as a pituitary adenoma or an adrenal tumor. So if we start on the right, hyperglycemia, for sure, because cortisol is what we call a stress hormone. It protects the body under conditions of stress, and throughout every day we actually have some stress. The body is constantly being bombarded with different stressors. Okay, so cortisol is very important in our bloodstream. When it's secreted in excess, that's when you develop hyperglycemia. Why? Because the body is getting ready for some kind of stressor. So it's going to release more glucose into the bloodstream. And a lot of patients become diabetic when they're on excessive and long-term doses of glucocorticoids. Patients get a lot of CNS irritability, personality changes from being on steroids or from having an underlying condition causing too much steroids in the bloodstream. Sodium and fluid retention, so you get edema, right? So glucocorticoids retain fluid, so you can get edema in your legs. You could get potentially pulmonary edema because of all the fluid retention. So we have to think of that in a patient with congestive heart failure. It thins your skin. Okay, so it makes patients have bruises on their arms and legs, very thin, fragile skin. It's hard on the gastrointestinal system. It thins the tissue in the stomach, leading potentially to peptic ulcers. In females, often too much cortisol will upset their cycles, and they can become amenorrheic, meaning loss of menstrual cycles. You can develop purple strands on your abdominal wall, for example. So they're called striae or stria. And what are those? Well, that's the bruising showing through the tissue, okay? Because the tissue is thinning. The bruises and petechiae we mentioned, that's from the thin, fragile skin, and blood vessels are breaking underneath it. Osteoporosis, cortisol really thins the bones, and it can lead to osteoporosis. In actual fact, patients that are on long-term prednisone often require treatment to prevent osteoporosis, such as calcium, vitamin D, and other medications to try and prevent the osteoporosis from the cortisol. You can get fat deposits on your upper back that we call a buffalo hump. So it's typically at your lower neck. You can get fat deposits of your face, and your face gets this rounded appearance that we call a moon face. Men can get gynecomastia. Why? Well, cortisol is a steroid hormone, and so is testosterone. It's a steroid hormone. So, and estrogen is a steroid hormone. So because there's some similarities to them, men can get a bit of breast stimulation from the cortisol that acts a bit like estrogen, and they can get small breasts. Okay? And another important one is steroids suppress the immune system. They shut down the inflammatory response. And that's partly why we use them so much, because in autoimmune diseases, that's exactly what we want. But unfortunately, that makes the patient very susceptible to infections. Okay? So have a good feel for all of these, because they're very important with anyone that's on long-term corticosteroids. Okay, so let's talk about really the opposite of Cushing's syndrome, which is Addison's disease. And Addison's disease is a loss of cortisol secretion from the adrenal gland. So it can be either due to adrenal failure, adrenal cortex failure, or it can be due to a lack of ACTH production from the pituitary gland. Definitely the most common one is adrenal cortex failure. So the adrenal glands are unable to produce and secrete cortisol into the bloodstream. And another hormone that's made in the adrenal cortex is aldosterone. And sometimes aldosterone will also be deficient because the adrenal cortex is diseased or destroyed, and there's no longer secretion of cortisol or aldosterone. So whenever we talk about a disease and we refer to it as primary or secondary, primary means the organ that is secreting the hormone that we're talking about is the problem. So primary Addison's disease is from adrenal failure. Secondary Addison's disease is from pituitary failure, and there's no secretion of ACTH to stimulate the adrenal gland. Definitely the first one's the most common, primary Addison's disease. Okay, so let's look at some symptoms of Addison's disease. So a lot of them are the opposite of Cushing's syndrome, which is excessive cortisol. So in Addison's disease, you may have hypoglycemia, which of course is going to bring weakness along with it. You can have postural hypotension. Remember, cortisol is responsible for maintaining blood pressure. It's one of the hormones that's responsible for maintaining blood pressure. So a lack of cortisol in this disease results in hypotension. Often people come in with gastrointestinal symptoms, abdominal pain, nausea is very common in Addison's disease. Why do you get bronze pigmentation of the skin? Well, that occurs not because of the lack of cortisol, but because of the excessive ACTH that's now being produced to try and stimulate the adrenal glands. And ACTH is able to stimulate partially the melanocytes in your skin, and you get bronze pigmentation, almost like a tanning effect of the ACTH's effect in the skin. Okay, so if you were to think of Addison's disease, you would think of someone who has abdominal pain, profound weakness, low blood pressure, and bronze pigmentation. Okay. Just to go back to Cushing's syndrome for a minute, those patients also have significant hypertension. Okay, that wasn't on the slide, but remember, Cushing's disease causes hypertension as well. So what's adrenal crisis? Well, adrenal crisis really is profound loss of cortisol in the circulation. So it's just going to be a more severe set of symptoms. So profound fatigue, dehydration. Why do you have dehydration? You've lost aldosterone, and aldosterone reabsorbs salt and water. So and it secretes potassium, right? So with this loss of aldosterone, you're losing fluids, you're losing sodium, and you're keeping potassium, since aldosterone was responsible for secreting potassium into the renal tubules. So you can just think of it as someone who's profoundly dehydration from all this fluid loss. They have high potassium, low sodium, and profoundly weak. Okay, so very different than Cushing's syndrome. So know the differences between the two. Okay, so what kind of drugs do we have to help with adrenal cortex disorders? So if you have an excess of cortisol, you typically are facing a surgical procedure. So for example, if we find you have Cushing's syndrome based on an adrenal tumor, then the adrenal tumor will need to be removed. If we find that you have Cushing's syndrome based on excessive ACTH secretion from a pituitary adenoma, typically the pituitary adenoma is removed. And like all adenomas of the pituitary gland, it's usually done through your nose. So the surgery is done through your nose, and that's called transsphenoidal surgery. Okay, the pituitary gland is actually very close to the back of your nose. Okay, so it's very accessible that way. So what about Addison's disease? Well, in Addison's disease, you have a deficiency of glucocorticoids and mineralocorticoids. So patients with Addison's disease often need replacement of cortisol, often in the form of hydrocortisone tablets that they take daily, and another medication called fludrocortisone, and that is a replacement for aldosterone. Okay, so the hydrocortisone is to replace the deficient cortisol levels. The fludrocortisone is to replace the deficient aldosterone levels in Addison's disease. Okay, so let's talk about hydrocortisone. And when we're talking about hydrocortisone, we could be talking about any glucocorticoid. They all have the same effects and the same side effects. So it could be prednisone, it could be dexamethasone. Okay, the fludrocortisone, I think I would just consider that a replacement for aldosterone. Okay, but hydrocortisone, prednisone, dexamethasone, they're all glucocorticoids, no matter which one we use. So they're indicated for adrenocortical insufficiency, which is Addison's disease. Now, we use steroids or glucocorticoids all the time in inflammatory conditions. So we could use it in rheumatoid arthritis. We could use it in systemic lupus erythematosus. We could use it in allergic reactions, such as poison ivy. We could use it in severely itchy rashes, such as eczema. So anything where we want to suppress the immune system, we can also use glucocorticoids. Or any allergic condition where we want the immune system to back off, because it's often the immune system reacting to something that's causing all the symptoms, we can use a glucocorticoid. Okay? So other examples of inflammatory conditions where we often use glucocorticoids, Crohn's disease, which is a disease of the gastrointestinal system, ulcerative colitis, another disease of the gastrointestinal system, asthma, which is an inflammatory condition of the bronchial tubes. Any of those, we could use a glucocorticoid. Okay, so in this slide, we're talking about hydrocortisone for replacement of Addison's disease, but remember, they're used for all kinds of conditions. So what about the adverse effects? Well, we went through that on a slide not too long ago. But definitely when you have too much of a steroid or a glucocorticoid in your system, whether you're taking it for asthma or rheumatoid arthritis, or you're using it for replacement in Addison's disease, you can develop diabetes, right? Glucose intolerance, which is you're developing diabetes. Thinning of the bones, osteoporosis. I'll come to adrenal suppression in a minute. Peptic ulcers. So we use the term peptic ulcers to refer to gastric ulcers or duodenal ulcers. Okay, peptic just comes from the term pepsin, and pepsin is an enzyme in your stomach. And if you remember, you typically have a very low pH in your stomach, and steroids thin the lining of your stomach. They're irritating to the lining of your stomach, and they can result in peptic ulcers. Okay, infection. So you are immunosuppressed if you're on an oral or an IV glucocorticoid, no matter what you're taking it for. You can develop Cushing syndrome if you're taking, say, long-term prednisone for an inflammatory condition, such as, let's just use rheumatoid arthritis for simplicity. Okay, you will develop all the symptoms and signs of Cushing syndrome. Retention of sodium and water. So steroids can do that. Any steroids can do that. Any of the glucocorticoids tend to help with reabsorption of sodium and water, and definitely fludrocortisone will do that even more, and that's what it's used for. It's for replacing aldosterone. Okay, so it's really important that you know the adverse effects of glucocorticoids, and I think on one of the slides in the notes they're listed. I think there's about 12 or 13 adverse effects, and once you know them for one glucocorticoid or steroid, you know them for all, because they all do it. Okay, there's some that aren't mentioned on here, such as hypertension. They lead to cataract formation in your eyes. They lead to thinning of the skin, bruising of the skin, those purple striae that we spoke about in a slide above. Many adverse effects that you should know for glucocorticoids. Okay. For monitoring of patients that are on glucocorticoids for whatever condition, we definitely monitor them for development of diabetes, and we also monitor diabetics because their sugars often become out of control. They become very elevated. So often their medications need to be adjusted because the glucocorticoids are causing them to have hyperglycemia. So if they're on insulin, often the insulin needs to be increased, or if they're on oral medications for their diabetes, they sometimes need to be increased. Monitoring of weight, because you gain weight on these medications. Not only do you retain sodium and water, but these stimulate appetite and you tend to eat a lot more. So patients definitely gain weight. Blood pressure we spoke about, they can all cause hypertension. Electrolytes can be affected because you're reabsorbing sodium and water, so they can be affected. Any glucocorticoid, or in quotation steroid, when we use them, we give the advice of taking them with food because they are irritating to the stomach, and we tell patients to take them in the morning. Why? Because steroids are stimulating and they cause insomnia if taken in the evening. So typically patients take them in the morning to try and avoid insomnia. Okay? We watch for potential upset stomachs, peptic ulcers, bleeding from peptic ulcers. Any of those can happen with ongoing use of hydrocortisone or any steroid. And someone who has Addison's disease and is reliant on taking hydrocortisone, under stressful times, such as an illness, they need more hydrocortisone. Because remember, it's a stress hormone. It's responsible for activating and helping the body under stressful conditions. So someone who's undergoing a surgery, say, or is sick in hospital, they may need higher doses of their hydrocortisone as a replacement. Okay. The other thing to remember with any steroid administration, not for Addison's disease, because they're on it for the rest of their lives. Okay. But say a patient is taking a steroid, such as hydrocortisone or prednisone, typically after around 3 weeks, the dose needs to be tapered down. It can't be stopped abruptly. So let me give you an example. If someone's taking 5 days or 7 days of glucocorticoid for a flare-up of asthma, they can just stop it abruptly. If someone's on a glucocorticoid for beyond around 3 weeks, it now has to be slowly tapered down. So the dose has to be gradually reduced over days to weeks. And the reason for that is after the span of 3 weeks, the pituitary gland has been turned off by the circulating glucocorticoid that the patient's been taking. So if they were to stop it abruptly, what would happen? They would suddenly go into an Addisonian crisis, meaning the cortisone in their body would go to 0 because the pituitary gland hasn't been turned back on and ACTH hasn't started to be secreted again, and the adrenal gland hasn't begun to produce cortisol. So they will develop what we call an Addisonian crisis, and they'll get all of those symptoms that Addison's disease comes with. Okay, so remember about the tapering of a glucocorticoid, typically after 3 weeks, or with long-term use. We always taper them. Okay, fludrocortisone, we won't spend much time on. This is really an aldosterone replacement in the setting of someone with Addison's disease that isn't producing glucocorticoids, but more importantly for this drug, they're not producing aldosterone. Okay, so this acts as aldosterone to reabsorb sodium, reabsorb fluid, and secrete potassium into the renal tubules. Okay, so definitely monitoring of blood pressure because this is acting as aldosterone. And if we give too much, we're going to reabsorb too much sodium and too much fluid and potentially cause them to be hypertensive and have abnormal electrolytes. So that's why the electrolytes are also monitored. Checking weights frequently, very important, because we're forcing the reabsorption of sodium and water. So we want to know if someone is gaining too much weight in the form of fluid. Okay. Advising patients about a low sodium diet. Why is that? Well, this drug is reabsorbing a lot of sodium, right? So we don't want them to have high sodium diets. Advising on potential for potassium supplements, because this drug drains you of potassium. So as it reabsorbs sodium, it's getting rid of potassium in the renal tubules. Okay? Okay, so let's move on to two other conditions that occur due to posterior pituitary diseases. So the first one is called diabetes insipidus. This has nothing to do with diabetes mellitus, which is the sugar diabetes. Okay, other than the name diabetes, it has nothing to do with it. So diabetes insipidus is a lack of antidiuretic hormone, and when you're lacking ADH, you're unable to reabsorb fluid in your renal tubules. And this leads to tremendous amounts of fluid loss. Okay, so a patient with diabetes insipidus will make tremendous amounts of urine, and it will be very, very dilute urine. And as well, they will have more concentrated serum. So it can lead to dehydration and elevated electrolytes, such as hypernatremia, high sodium. Okay, so very dilute urine, very low specific gravity in the urine, meaning it's not concentrated at all. But the serum is typically elevated in electrolytes because it's more concentrated. Less fluid has been able to be reabsorbed. Okay, SIADH is syndrome of inappropriate ADH secretion, so too much ADH production. And this can come from the pituitary gland, so excessive pituitary gland production. But there's certain cancers that can also make this hormone. And one of the main ones is lung cancer. Lung cancer can actually make ADH. And what happens when you have too much ADH? You reabsorb too much fluid in the renal tubules. So you become volume overloaded. You develop edema, in particular of your legs. You can go into pulmonary edema. So basically you're water intoxicated because you're reabsorbing so much of the fluid in your kidneys. And you would be hyponatremic. You would have low sodium because your serum is so dilute. And if we were to talk about your urine, it would be concentrated. It would have a high specific gravity. Okay, so desmopressin, or another one, vasopressin, is the replacement for ADH. Okay, so basically they're identical. This will replace the ADH deficiency in someone with diabetes insipidus. We can actually also use it in children that have grown to a certain age. Let's use, for example, an 8, 9, or 10-year-old that still continues to have bedwetting. And we can use desmopressin to help reabsorb fluid through the night from the kidneys to minimize the amount of urine that's in the bladder, so it reduces bedwetting. Okay, so that's not an uncommon reason for using desmopressin. Okay, vasopressin actually used to be used in replacement of epinephrine during CPR in a cardiac arrest. We tend to use it less and less now. We've moved back to using epinephrine for a cardiac arrest and CPR. Okay, so really the main indication that we're talking about here is replacement of ADH in diabetes insipidus. The other condition that isn't listed here that we use desmopressin for is a clotting disorder called von Willebrand's disease. And basically von Willebrand's disease, if you haven't done it in one of the modules, you will do it, is an issue with the platelets not binding together very well, forming a platelet plug. And so patients typically have bleeding, bleeding gums, bruising, bleeding post-dental procedures because they're missing a factor and that helps bind the platelets. And desmopressin increases the level of that factor that helps bind the platelets. So it can be used in von Willebrand's disease to help promote the platelets to bind together. Okay, so how does it act? It acts on the kidneys to reabsorb fluid, okay, water. So what are the adverse effects? Well, when you're reabsorbing large amounts of fluids, congestive heart failure, hyponatremia if too much is given, which can then lead to the symptom of a headache, because when you're hyponatremic, fluid will leave the intravascular space and go into the cells of the brain. Okay, so the symptom would be headache, nausea, decreased level of consciousness, and even potentially seizures if you become very hyponatremic. Okay, who would we avoid this in? Well, anyone who has a cardiac condition, because we're going to potentially volume overload them. Anyone who's hyponatremic already, they're going to become more hyponatremic. Okay. What considerations do we think of with someone who's on desmopressin or vasopressin? Well, definitely monitoring the vital signs, since you're reabsorbing so much fluid. You want to know the blood pressure and their volume status, and input and output of fluids. Okay, that gives us a good idea of how much volume or how much fluid are they retaining. The specific gravity of the urine could be helpful because that should be normal while you're on this medication. So it's generally all about monitoring volume status, vital signs, electrolytes that can become abnormal, such as hyponatremia, monitoring daily weights while patients are receiving this. Typically it's given intranasally for children with bedwetting, but this medication can be given subcutaneous, intravenous, or orally. Okay. Okay, so on to the next topic, diabetes mellitus. This slide is just to remind you, diabetes mellitus has nothing to do with diabetes insipidus. Okay, diabetes mellitus is a issue with glucose metabolism and glucose control in the serum. Diabetes insipidus is lack of antidiuretic hormone. The only reason why they're both called diabetes is because they have some similar symptoms, such as urinating a lot in both of them, drinking a lot in both of them. So someone came up with the idea of calling them both diabetes. I think that's very confusing, but diabetes mellitus that we're going to talk about is much, much, much more common than diabetes insipidus. And we'll spend quite a bit of time talking about diabetes mellitus coming up. And we'll discuss the different types of diabetes, such as type 1 diabetes, type 2 diabetes, and gestational diabetes. And hopefully by the end of this module, you'll have a really good feel of what diabetes is all about. Okay, so what's a normal response that the pancreas gives in the setting of increased glucose? So, for example, you have a meal or you drink a pop that has sugar in it, and you raise your serum glucose level. What's the response? The pancreas is going to produce insulin. What does insulin do? So the pancreas, first of all, detects the elevated glucose level and secretes insulin into the bloodstream. Insulin allows glucose to enter cells, okay, where it can be used for energy. So it can go into muscle cells, it can go into fat cells for storage. Insulin helps glucose go into the liver to be stored as glycogen. So basically it's getting glucose out of the serum and into the different cells of the body. Okay, that's the normal response. And your pancreas wants to keep your serum glucose in a very tight parameter, typically around 70 to 100. Why does it want to do that? Because it never wants you to have hypoglycemia, because that would be dangerous for the brain. The brain uses glucose almost primarily as its food source. So it's going to do everything it can to protect from hypoglycemia. And hyperglycemia leads to increased urination, increased thirst, so it starts to give you symptoms. So the body keeps the serum glucose in very, very tight parameters under normal circumstances. Okay, let's look at type 1 diabetes. So type 1 diabetes is an autoimmune disease that typically you develop in childhood, adolescent, early adulthood. That's by far the most common time to develop type 1 diabetes. And it's autoimmune destruction of the beta cells in the pancreas that produce insulin. So there's absence of insulin. So now when you eat a meal or you drink a fluid with sugar in it, there's no insulin response. So the glucose can go to extremely high levels. But that's the least of the person's problem, okay? Not only do they have high serum glucose, but the absence of insulin is an indicator to the body to start breaking down glycogen and even adding more to the problem. So glycogen breaks down to more glucose in the body. The absence of insulin now allows the fat cells in the body to start breaking down fatty acids, because all of these cells think that because there's no insulin, the body must need energy. Okay, so the liver breaks down glycogen, the fat cells start to break down fatty acids, and when fat cells break down fatty acids, in order to help out, they produce even more glucose, but in the process of the breakdown, they produce a lot of acids. So in type 1 diabetes, the main issue that makes people extremely sick when they're initially diagnosed, or if they stop taking their insulin, is ketoacidosis. Because those fatty acids are now allowed to break down in the absence of insulin, they are making ketones, and ketones are acidotic. So the patient becomes or develops a metabolic acidosis. Okay, so not only do they have elevated sugar because there's no insulin, and they're drinking lots, they're urinating lots, they're dehydrated. The more important and deadly condition is the metabolic acidosis that comes along with type 1 diabetes. And you're going to see that it's very uncommon to have metabolic acidosis in type 2 diabetes. And I'll explain why in a minute. Okay, so remember, the absence of insulin not only causes the glucose to be elevated, it leads to a metabolic acidosis in a patient, and that's why they become so deathly ill. Okay, so in type 2 diabetes, the issue is not an autoimmune disease that's destroyed the beta cells in the pancreas. So the pancreas is able to make insulin, but because of a number of factors, obesity being one of the most common, the cells have become resistant to the insulin. So cells around the body that typically responded to insulin and allowed glucose into the cells, they've become insulin resistant. And the most common reason in North America is obesity. Now, we mentioned cortisol as potentially causing diabetes. So there's other reasons someone can develop type 2 diabetes. And by the way, type 2 diabetes is much, much more common than type 1 diabetes. And typically, type 2 diabetes you develop into your 40s and 50s and 60s. It's often related to weight gain. That's not always the case, but for the majority of people. Okay, so it's an insulin resistance. There's enough insulin in the bloodstream. The pancreas is still working, but the insulin is being ignored by the cells, and that's why you have high glucose levels. Okay, now the insulin is still telling the liver to make glycogen, okay, to store it, and the insulin is still telling the fat cells, store glucose, don't break down the fatty acids. I don't need you right now. I don't need extra energy because I have glucose and I have insulin to send glucose into cells, or at least try. So that's why you don't get the ketoacidosis. The fat cells don't break down the ketones. Okay? The insulin stops them from breaking down the ketones and creating a metabolic acidosis. So what are you left with in type 2 diabetes? You're left with elevated glucose levels. You don't develop metabolic acidosis, but you can get all the complications of diabetes. And the complications we'll discuss in another slide, of either having type 1 or type 2 diabetes. But think of them as different diseases. One's an insulin deficiency and one's an insulin resistance. Okay? Now, over years of having type 2 diabetes, can the pancreas finally exhaust itself and then result in declining insulin levels? Sure, that can happen. But for the most part, type 2 diabetes, there's enough insulin circulating in the bloodstream. There's just not enough cells that are responding to the insulin and allowing glucose to enter the cells. Okay, so this slide is just reminding you that the body, most cells of the body, whether it's the muscle cells or the brain cells, prefer glucose as its primary source of energy. Okay? Most cells in the body do not want to use protein as their primary source of energy or fat. They want to use glucose, okay, to make ATP. Okay, the normal serum level of glucose, approximately 70 to 110. That's the typical normal range. And we discussed why it is so tightly controlled, okay, with insulin. And another hormone that's secreted by the pancreas called glucagon. So insulin allows glucose to go into cells all over the body. Glucagon stimulates the liver to break down glycogen into glucose. Okay, so they're opposing hormones that are produced by the pancreas. Okay, so let's keep moving forward here. And remember, when we're talking in this module, we're doing a lot of pathophysiology. So this will definitely translate over to pathophysiology that you're also doing. Okay, and it's really important to have that so that you can understand the drugs and the insulins that we're talking about. Okay, so it's definitely going to be a longer module than usual, but it's just to provide you with the information you need, which is the pathophysiology plus the pharmacology. Okay, so physiology of serum glucose. Well, we just spoke about that there's two pancreatic hormones that contribute to stabilizing the serum glucose. One of them is insulin, which will reduce serum glucose. How does it do it? It allows glucose to go into cells around the body. It allows glucose to go into the liver and be stored as glycogen. Okay? And then there's glucagon that will detect low levels of serum glucose. And when glucagon is secreted by the pancreas in the setting of hypoglycemia, it's going to stimulate the liver to release glycogen and convert it to glucose. Okay, so it's all about controlling serum glucose levels, which is the main food source of the body. Okay, so this slide's important because remember, insulin deficiency in type 1 diabetes doesn't just lead to high serum glucose. It leads to a cascade of events that cause metabolic acidosis, and that lowers your pH significantly, and people become extremely sick with it, okay? And that typically happens in type 1 diabetes, not so much in type 2 diabetes, because there isn't a lack of insulin in type 2 diabetes. Okay, so insulin, what does it do? I know I've mentioned this before. It promotes entry of glucose into cells. It promotes entry of glucose into the liver to be stored as glycogen. It tells the fat cells not to break down, that there's no need for fat to break down and become sugar. So there's no chance of becoming ketotic or developing a lot of ketones in the blood. It also tells the liver to produce proteins that it wants to make, because it doesn't need the proteins to break down into glucose for energy. So insulin is basically telling all these areas of the body, I have enough sugar in my bloodstream. I'm going to help it get stored in the fat cells, get stored in the liver, and also help it get into cells for energy production. Okay? And The opposite will happen in insulin deficiency in type 1 diabetes, and we'll talk more about that. Okay, so type 1 diabetes. So of the two diabetes, type 1 and type 2, type 1 is less common. Okay, it's an autoimmune disease, as I said, typically in children and young adults, and it makes up about 10% of all the diabetes in the population. Okay, and because of the destruction of the beta cells, there's complete absence of insulin, and you cannot survive without insulin. Okay, because your body will just break down proteins and fats around the body to try and produce more glucose because of the lack of insulin. So insulin is the only treatment for type 1 diabetes. There's no pills, there's really nothing else except insulin injections. Okay? So we know it's an autoimmune disease. We know there's a genetic component. It does run in families. Both types of diabetes do. And there's environmental factors that we're not totally clear on that can trigger type 1 diabetes. Okay? Absolute requirement for insulin injections in order to survive. Okay, type 2 diabetes, by far the most common type of diabetes. Typically, it's due to the aging process. So as I said, as we get into our 40s, 50s, 60s, we're starting to gain weight. There's definitely a direct link to obesity and developing type 2 diabetes. There's also a genetic component to it. And this type of diabetes makes up about 90% of diabetes, right? And it's not the lack of insulin resistance. Often there's high levels of insulin in the bloodstream, but it's the cells that do not respond to the insulin. It's the insulin resistance that occurs, which leads to rising glucose levels in the bloodstream and causing symptoms of polyuria, polydipsia, polyphagia, fatigue. So you can see that patients with type 2 diabetes don't get super ill like they do in type 1 diabetes when they don't take their insulin. Okay? And what happens in type 2 diabetes as well is because of the high insulin levels, because the pancreas is doing everything it can to get this glucose into cells, because of the high insulin levels, it's telling the fat cells to store more fat, keep more glycogen in the liver. So you tend to get weight gain. You tend to get a fatty liver, it's called, okay? All because the insulin is saying, you know what, just move this sugar somewhere, store it somewhere. So it ends up going into fat cells as fat storage and into the liver as more and more glycogen, and you can develop what's called a fatty liver. Okay, so here's a lovely image of the two different types of diabetes. I won't spend too much time. Type 1 diabetes, lack of insulin, inability for glucose to get into the cells, in this case, a muscle cell. Type 2 diabetes, there is insulin, but the muscle cell and other cells around the body are not responding to the insulin, so glucose can't get into the cell. Okay, so very different diseases. I know they both cause elevated glucose levels, but because of the first one, type 1 diabetes, not producing insulin, you can become extremely ill from that lack of insulin and developing diabetic ketoacidosis. Okay, the long-term complications of both diabetes are quite similar, and we'll talk about them in an upcoming slide. Okay, so this slide's giving you a comparison of type 1 and type 2 diabetes. And I think we've covered most of this. Type 1 being destruction of the beta cells and lack of insulin. Type 2 being insulin resistance. And potentially later on insulin deficiency as the pancreas gets fatigued. But think of type 2 diabetes more as insulin resistance in the target cells. The differences in incidence: type 2 diabetes by far more common than type 1. Age of onset: children and young adults in type 1 diabetes. Typically older people beyond 35, typically 40s, 50s, and 60s, develop type 2 diabetes. Symptom onset: type 1 diabetes, rapidly sick with acidosis and hyperglycemia. Type 2 diabetes, more gradual, kind of just gradually increasing sugar levels, but they don't get severely ill typically because they don't get the acidosis. Body weight: type 1 diabetics aren't usually overweight. I mean, they can be, but usually they're not overweight. It's just an autoimmune destruction of the pancreas. Type 2 diabetes, often overweight or obese, which leads to the insulin resistance. Okay. Type 1 diabetes, they're the ones that get ketoacidosis from the lack of insulin. Type 2, very uncommon for that to happen. What's the treatment? In type 1 diabetes, it's insulin only. Okay, that's the only treatment you can give someone with type 1 diabetes for them to survive. In type 2 diabetes, it ranges. It can range to diet control and exercise, and then we can progress to oral anti-diabetic medications to help control serum glucose levels, and then finally we can progress to insulin therapy to control their glucose levels. Okay, so this slide's just giving you some common symptoms of hypoglycemia versus hyperglycemia. So how do you become hypoglycemic? Well, it's either you've taken too much insulin, or you've taken insulin and you missed a meal, or you've taken insulin and went out and did tremendous amount of exercise, which dropped your glucose level, or you took an oral anti-diabetic medication that forced your sugars to go to a low level. Okay, so hypoglycemia is typically occurring from either too much insulin, or insulin followed by a missed meal, or an oral anti-diabetic medication that caused hypoglycemia. Okay, you don't just suddenly become hypoglycemic without one of those scenarios occurring. So what kind of symptoms do you get? Well, it's usually the sympathetic system turning on, saying, do something to get your blood sugars elevated again. So sweating, paleness, irritability, that's the sympathetic nervous system being activated to warn you that your sugars are dropping. Your brain will also warn you that, okay, you should be hungry right now. Your sugars are dropping in your bloodstream. The lack of coordination, the sleepiness, and finally the unconsciousness is the dropping levels of glucose in the brain. So the brain needs sugar to run all its processes. So as you become hypoglycemic, you're going to get dizzy. You're going to be off balance. You're going to be lethargic. And finally, as your as your glucose levels drop, you'll become unconscious. Hyperglycemia too much sugar in the bloodstream is going to lead to loss of a lot of glucose in your urine. And that's going to cause you to lose fluid with all that glucose. So you're going to become dehydrated. So you'll have a dry mouth, increased thirst. You're going to feel weak because yet you're losing all this sugar in your urine. And we'll pick up the sugar when we check the urine with a urine dipstick. Okay? Blurry vision because glucose gets into the cornea of the eyes and it causes blurriness. So people often come in complaining of, I'm thirsty, I'm urinating a lot, and I have blurry vision when they have hyperglycemia. Okay? Okay, let's go on to the next slide. Okay, so here is hypoglycemia again, and here are all the symptoms you can develop. And just think of, as your sugar levels go below 70, your body's going to start to become very nervous. And as I mentioned before, it's typically from the use of insulin in a diabetic, or some of the oral hypoglycemics can cause hypoglycemia. And if you look at the symptoms here, most of them are going to be related to the sympathetic system, the shaking, the sweating. You're getting anxious, dizzy, tachycardic. And this will progress as the sugar goes to lower and lower levels to the point of weakness, decreasing level of consciousness, and finally a hypoglycemic coma. Okay, so this is just a interesting slide on the incidence of diabetes. You can see that it's definitely becoming more and more of a problem in North America. Look at that number, 25% of all people over 65 years of age have diabetes, and most of them will have type 2 diabetes. Okay, so another type of diabetes is gestational diabetes. And this is diabetes that develops during pregnancy. It's not a woman that goes into pregnancy with type 1 or type 2 diabetes already. It's someone who develops diabetes during pregnancy. And diabetes is a bit of a, pregnancy is a bit of a stress test on the pancreas and on the cells of the body. So during pregnancy, what happens? There's increasing weight, there's increasing demands for insulin. Because of the increasing weight, you get insulin resistance. So the pancreas starts to produce more insulin to try and get the sugars or the glucose into the cells. And if you were potentially prone to developing diabetes later in life, you may develop gestational diabetes during pregnancy. Okay, so it's a insulin resistance problem, just like type 2 diabetes. Okay, and it doesn't necessarily have to happen with the first pregnancy. It could happen with the second or the third. Okay, and it does put the mother and the fetus at risk, and we'll talk about that. And the risk of developing type 2 diabetes after having had gestational diabetes is significantly higher. And why is that? It's because the gestational diabetes stressed the body a bit to see, okay, can you tolerate this extra weight and this pregnancy? And if the woman developed gestational diabetes, it's an indicator that later in life, 5, 10, 15 years later, that she will develop type 2 diabetes. Okay? So what are the risk factors for developing gestational diabetes by itself? Well, if you're already overweight, that's a risk factor because that already produces insulin resistance. A history of gestational diabetes in another pregnancy, a family history of type 2 diabetes is also a risk factor. Okay? So really see it as a stress test on the body when a woman is pregnant because of the weight gain that causes insulin resistance, and some women develop gestational diabetes. Okay, so again, as mentioned, it's an insulin resistance. It's not lack of insulin. It's just that the insulin doesn't work very well around the body. And if it's not treated properly, what's going to happen? Well, the mother's going to have high sugar levels in the bloodstream, high glucose. And glucose goes across the placenta into the fetus. So the fetus is going to have high glucose levels. The fetus's pancreas is going to produce higher levels of insulin to try and clear all this glucose that's in the fetal circulation. And when you have higher levels of insulin, you store more glucose as glycogen, you store more glucose as fat, and you get a larger fetus, okay? Macrosomia. And that's a problem because macrosomia in a diabetic mother, like a gestational diabetic mother that has a large infant due to diabetes, can make it very difficult to deliver. Okay, so they can be much larger than a typical fetus at term for delivery. Okay, now once the mother delivers, typically with the weight loss, the diabetes resolves. The gestational diabetes resolves, but the risk of developing type 2 diabetes later on in life is significant. Okay? Okay, so let's get into the therapies. Hopefully we have a good feel for type 1 diabetes, type 2 diabetes, and gestational diabetes. And by the way, I didn't mention in gestational diabetes, typically with gestational diabetes, we use insulin as the treatment to control the serum glucose. Okay, that's the main treatment. And then following delivery, you typically don't need the insulin any longer once the gestational diabetes has resolved. Okay, so insulin therapy in type 1 diabetes, it's a necessity for survival. In type 2 diabetes, insulin is sometimes used, but typically we try diet, exercise, and oral medications to control type 2 diabetes. Okay? Now, if someone needs to start insulin therapy, whether it's for type 1 or type 2 diabetes, there's some significant planning that needs to occur. When do you take the insulin? How much do you take? Do you take it with each meal, or do you just take one shot that lasts all day? So it's a matter of finding the right combination of short-acting insulin, long-acting insulin for a particular patient. Okay, and it requires a lot of monitoring. So we use glucometers to monitor serum glucose to make sure that someone isn't hypoglycemic or significantly hyperglycemic. Hypoglycemia, possibly leading all the way to hypoglycemic coma, occurs if insulin is given and then someone doesn't have a meal or something with glucose in it, and the insulin continues to drop the serum glucose. Okay, so patients at home, patients in the hospital, they're getting regular glucose checks with a glucometer, okay, to follow the level of serum glucose. Okay, for the rest of this module, we're just going to talk about insulin products, so different types of insulins. Some will be very rapid acting insulins, some will be slow acting insulins, and we'll talk about the advantages of both of them. So remember, insulin is an absolute requirement for type 1 diabetes, and we use it in gestational diabetes. For type 2 diabetes, which is by far the most common diabetes, we use a mixture of diet, exercise, oral hypoglycemic medications, or oral anti-diabetic medications, and then if needed, we use insulin. Okay, so insulin is drawn up by the units. Okay, so not by milligrams, but by units. And an insulin syringe contains, or can contain, 100 units of insulin. And so there are specific syringes, right? Specific insulin syringes that hold 100 units. The insulins that we're going to talk about, some will be cloudy, some will be clear, just naturally, and we'll talk about that. So there's an assortment of insulins ranging from very rapid onset to very slow onset with a long duration. So for example, when we're going to be talking about regular insulin or some of these other ones that are listed, such as Lispro, Aspart, Glulisine, these are rapid acting insulins, at least the last three. Regular insulin is what we call short acting, meaning it works fast, but not as fast as Lispro, Aspart, or Glulisine. Those are rapid acting. Okay, and really they're the only insulins that if we needed to, we would use IV. But when you're thinking of intravenous insulin, why would we ever do that? We would use it for someone who has become very ill with diabetic ketoacidosis. Okay, we use IV insulin for that condition, and it's almost always regular insulin. Okay. Otherwise, insulin is given subcutaneously. Okay, never oral because it's a protein. It'll be broken down by the gastrointestinal tract. Okay. Now we can also have pumps, insulin pumps. That's giving a continuous infusion of insulin, very low dose throughout the day. And then the patient can press a button on the pump when they're going to have a meal, and they'll get a bolus of insulin to process the meal that they're about to have. And insulin pumps really only use rapid insulins, such as listed above, Lispro, Aspart, and Glulisine, or regular acting insulin. Okay. When we're talking about an antidote for hypoglycemia, what are the options? So say someone takes too much insulin and their sugar's dropping rapidly, 70, 60, 50, they're getting symptoms of hypoglycemia. If they're still awake, we can just give them something orally, some kind of glucose product orally. If they're semi-comatose or unconscious, we now have to go to an intravenous route to either give them a dextrose solution, such as D10 or D50, which is a highly concentrated dextrose solution intravenously to get their sugar back up quickly. Or we can give them an injection of glucagon, which will stimulate the liver very quickly to break down glycogen into glucose. Okay, so those are the options for bringing someone's sugar back up. If they're awake and still cooperative, okay, let's give them some orange juice or some kind of glucose substance. If they're semi-awake or unconscious, we have to give them an intravenous glucose solution or an injection, typically intramuscular, of glucagon. Okay, so let's look at some common insulin groups. And it's really based on onset of action and peak duration. Okay, so when does it start to work? When does it peak? And how long does it last for? So we now have rapid acting insulins that we'll talk about. We have short acting insulins that have been around for a long time, intermediate acting insulins, and then we have long acting insulins, which is typically insulin glargine. And there's another one called insulin detamers. All right, so and why do we have all these insulins? Rapid, short, intermediate, long. We can combine insulins to get the best overall serum glucose control. Okay, so often rapid insulins or short-acting insulins are used prior to meals. So say 3 times a day if you have 3 meals a day. And then intermediate acting, which gives a bit of background insulin for typically around 4 to 12 hours, can be used twice a day to give background insulin and glucose control. Or we can go to a long-acting insulin that's once a day and gives background insulin in the bloodstream that's continually working at a low level, and a patient can take rapid insulin at mealtime. And we'll give you some examples of that in the coming slides. Okay, so this slide is just showing you the onset and the duration of action, right? So when is someone going to take a rapid insulin, such as Lispro, Aspart, or glulisine insulin? Well, you're definitely going to take those before a meal, right? 15 to 30 minutes before a meal. Okay, because of such rapid onset of insulin action. Regular insulin, typically again, before a meal. Okay, so prior to having rapid insulins, which isn't that long ago, say 10 years, we just used regular insulins before a meal. Intermediate insulin, you can see that it peaks at around 4 to 6 hours, and it lasts about 12 hours. So typically we can use intermediate acting insulins twice a day to give a longer lasting insulin that goes beyond just the meal that you had and gives ongoing glucose control in the bloodstream. Or we can use a long acting insulin, such as glargine. If you look at the line there, it lasts about 18 to 24 hours, and it continually gives you some background insulin so that it gives good serum glucose control even between meals. Okay, so we often combine some of these, and we'll come to a slide where there's examples of combinations of insulins. Okay, so the top example is someone who's taking a rapid acting insulin before every meal, and Why do they do that? Because they're about to have a significant amount of glucose in their meal or carbohydrate. And what will that do? It's going to put up serum glucose levels. So you want a rapid acting insulin to work to reduce those serum glucose levels. So Lispro or aspart insulin will do that very quickly. So they're used before meals, typically 3 times a day. And then in this top example, the person will take 1 dose of insulin glargine, a long-acting dose, or a long-acting insulin, sorry. And insulin glargine is typically taken at bedtime, and it doesn't really even have a peak. It just lasts around 18 to 24 hours. So you can see it's basically a straight line for 18 to 24 hours. Okay, so that's one example that we could do for insulin therapy in a diabetic patient. The other one is still staying with a rapid acting insulin 3 times a day for meals, but instead of using a long acting insulin, you could use twice a day intermediate acting insulin, okay, which is NPH. And that gives background insulin as well to keep glucose levels at a decent level between meals. I find more and more patients are going to insulin glargine for that bedtime dose of a long-acting insulin, and then they take their rapid or short-acting insulin with meals. Okay, so this next slide is really a reference slide for you. Would I memorize it? Absolutely not. It's broken down into rapid insulins that we spoke a bit about, the Lispro, aspart, glulisine, short-acting, which is regular insulin, intermediate acting, which is NPH typically, or Lante, and then we're into long-acting insulin, the insulin glargine, insulin detamers, and again, it's just giving you onset of action, peak onset, and duration. Okay? And remember, these are often combined. Rapid or short acting is often combined with an intermediate or long acting to get better serum glucose control. And then at the bottom, we now use mixtures of insulins. So 70-30 insulin, which would be insulin 70% NPH, say, an intermediate acting, and 30% short acting. So, and you can get different percentages of mixtures, right? So 70-30 is a very common one. So a patient would take an injection of 70-30 in the morning. They'll have 30% of the insulin as regular insulin that'll work quickly. And then 70% will be the NPH, which will work for hours longer. Okay? So less and less is it necessary to mix insulins in a hospital or the emergency room or clinics, because they come pre-mixed now. Okay, so talking about mixing insulins, say we want to mix a rapid or a short insulin with an intermediate insulin. By the way, we never ever mix long-acting insulins. They're just too long-acting to mix with other insulins. They last 18 to 24 hours. They get injected by themselves. Okay, so mixing insulins is usually a rapid or a short insulin with an intermediate insulin. And what you really want to avoid is contaminating the clear insulin, which is your regular insulin. Your intermediate NPH insulin is typically cloudy. Okay, so When we want to get a mixture of insulins, we're going to take our insulin syringe, we're going to inject the number of units of air that we want to take the insulin later. So if you want to take 20 units of NPH insulin later, you'd inject 20 units of air. Okay? Take out the syringe. Don't take out any NPH insulin. And then take the syringe again and put in, say, 10 units of air into the regular insulin. And then tip the regular insulin upside down and withdraw your 10 units. Okay, so now you haven't contaminated the regular insulin with cloudy intermediate acting insulin. And then finally, you go back to your intermediate acting insulin and you withdraw your 20 units. So you're left with 30 units of insulin, 20 of which is NPH and 10 of which is regular. Okay, so that's the process of mixing insulins. Also, there's checking of cloudy insulins. So cloudy insulins should be evenly cloudy throughout. There shouldn't be clumps and floating particles throughout, or anything that's stuck to the side of the glass or at the bottom of the glass. So always checking the cloudy insulins to make sure that they're even throughout. Okay, so this slide is just showing you the mixing up of insulins, where you draw up the clear insulin, which is often the fast-acting insulin, before the cloudy insulin, which is typically the intermediate acting insulin. Remember, we don't typically draw up long-acting insulin. I know it says this on the slide, but they're really just referring to NPH, which is more of an intermediate insulin. The long-acting, such as insulin glargine, we don't draw those up at all. They're injected by themselves. They're not mixed with other insulins. Okay, so we're just going to have a prototype slide on a rapid, a regular, an intermediate, and a long-acting insulin. So just to help clarify it even more. So insulin, this is a rapid acting insulin, insulin Lispro, the brand name Humalog. You can see that it could be aspart, glulisine. They all have very similar actions and durations. And they can be used in type 1 diabetes, type 2 diabetes, or gestational diabetes. Okay? So what are the adverse effects of any insulin? Well, too much insulin can lead to hypoglycemia. Okay, and patients need to be aware of symptoms of hypoglycemia. Sweatiness, tremors, shaky, nervousness, pale appearing, decreasing level of consciousness. They need to be aware of those symptoms so they can do something about it, such as take some food or something to drink with sugar inside it. Hypokalemia, so insulin, when it allows sugar or glucose into cells, it takes potassium with it. Okay, so someone, for example, who's on IV insulin, we can make them hypokalemic just by the very fact of the insulin drawing potassium into the cell. Okay, the lipohypertrophy is really at the injection site. So if you think that insulin promotes sugar to go into fat cells, well, where you're injecting the insulin, it will promote that area to hypertrophy, to enlarge the fat cells, just by the injection site. So they can get lipohypertrophy, these sites of more swollen tissue called lipohypertrophy. And really, that's the reasoning for rotating sites for insulin, right? To avoid repeating the same site over and over, which will then lead to lipohypertrophy. Okay. Now, when we're talking about hypoglycemia, we mentioned that too high of a dose of insulin can cause it, too little food can cause it, an illness such as a diarrheal illness, and you're taking your insulin but you're not eating very much, if you're vomiting, for example, that could drop your insulin, your sugar levels too low. Alcoholics that are diabetics. Alcohol really messes with glucose metabolism, and they can become hypoglycemic from insulin injections. Okay. Strenuous exercise, if you're burning off a lot of calories, you're using the glucose that's in your bloodstream, and at the same time you're taking insulin, that can lead to hypoglycemia. Okay, so typically the monitoring of someone who's potentially hypoglycemic, it's all of those symptoms from the sympathetic nervous system, the tachycardia, the racing heart, palpitations, sweaty, shaking. Okay. Now, insulins and certain medications you have to be a bit careful with. So, for example, beta blockers that are used for cardiac conditions such as angina or hypertension or congestive heart failure, well, they're blocking the sympathetic system. So as somebody potentially becomes hypoglycemic from taking, say, too much insulin, they won't get the warning signals from the sympathetic system because they're on a beta blocker that blocks the sympathetic system. Okay. Glucocorticoids, well, we were talking about Cushing's disease earlier. That raises blood sugars because it's a stress hormone. So it can make controlling someone's diabetes very difficult. For example, if someone's on prednisone, really hard to control their blood sugars while they're taking prednisone. They often have to have increased doses of insulin to keep their blood sugars under control. Now, some of the oral hypoglycemics that we're going to talk about cause stimulation of the pancreas to release insulin. So if you can imagine you're taking a pill that releases insulin from the pancreas and you're on insulin, you can become hypoglycemic. And we'll talk about some of those medications coming up. Okay, it's typically the sulfonylurea group. And we'll get to that. Okay. So let's carry on with the next insulin here. Okay, so regular insulin again can be used for any of the diabetes, but mandatory for type 1 diabetes. Okay, and typically used in gestational diabetes as well. So it's a short acting. It doesn't work as fast as the rapid insulins, but still people use it prior to meals to control serum glucose levels following a meal. That's typically what it's used for. And the adverse effects will be the same as any other insulin. When mixing short acting and intermediate acting, remember you draw up the short acting insulin first, followed by the intermediate cloudy acting, cloudy insulin, which is intermediate acting. Okay, if we ever need to use intravenous insulin, we use regular insulin. Okay, we could use rapid acting insulin, but it really has no advantage. We use regular insulin in diabetic ketoacidosis to get their serum glucose levels under control and to start to reverse the ketoacidosis that they have. That's the main reason for using IV insulin. Okay, so when you are mixing insulins, you typically gently rotate the vials between your palms just to mix up all the particles. Remember, the NPH in the pre-mixed insulins, they should be cloudy, right? They have an intermediate acting insulin in them which is cloudy. Okay, the long-acting insulins that are not mixed, they're typically clear. Okay, so insulin glargine and detamers are clear, just like the rapid and short-acting insulins. Okay. The other topic to remember is storage of insulin. So unopened vials of insulin are kept in the fridge, okay, until they expire. Once insulin has been opened, so the vial has been used, it can be stored at room temperature, okay, and then typically discarded after 1 month. Okay, so let me just finish up this slide with giving you an example. A patient, say, is 30 years old, comes to the emergency room because they're not feeling well, and we check their blood sugar, and their blood sugar is 400, so hyperglycemia. And then we discover, upon doing further tests, that they're acidotic. Their pH is 7.1. And so now that's telling us, okay, this is very likely a new onset type 1 diabetic with a metabolic acidosis. Okay, so because their sugar has been so high, they've become dehydrated. Typically, they've been urinating a lot. They've been trying to drink a lot because they're thirsty. But often they're dehydrated and they need intravenous IV solutions to rehydrate them. And most of the time we use normal saline for that. Okay, so we give them normal saline to rehydrate them, and at the same time we give them intravenous insulin. And by far the most common scenario or which insulin we use is regular insulin. Could we use a rapid acting insulin? We could, but it really doesn't offer any advantage over regular insulin. Okay, so they're getting lots of fluids to flush out the ketones, the acids that they've developed. We're rehydrating them with IV fluids, and at the same time we're giving insulin to lower the serum glucose and also to tell the fat cells to stop breaking down. Okay, that's what insulin does. It tells the fat cells to stop breaking down fatty acids. Okay, I won't spend too much time on this. Just an intermediate acting insulin, NPH. Remember, it's cloudy. It can be mixed with rapid or regular insulin to a certain percentage, say a 50-50 mix or a 70-30 mix. Just depends what percentage we want in the mixture. Or it can be given by itself, typically 2 injections a day. And as I mentioned before, we're moving more and more to 1 shot of a long-acting insulin instead of using 2 injections of NPH insulin. Okay, insulin glargine, that's a long-acting insulin. There's really no peak to it. It just gives background insulin throughout the whole day, even while you're taking your short-acting or your rapid-acting insulin. The adverse effects will be the same. Most people take this dose or this insulin at bedtime. Okay, There's no mixing of this insulin. It's clear in color, never given IV, and it's really to maintain better control of someone's daily serum glucose. Okay, here's just a pre-mixed insulin, very common one, brand name being Novolin 70/30. The 70/30 tells you the percentage of how much intermediate and how much short-acting insulin is mixed together. Okay, it can be used in any of the types of diabetes. The adverse effects are the same. And of course, with anyone who's taking insulin, we always advise them to have some kind of a glucose drink or food that's available in case they become hypoglycemic. Patients with diabetes need a lot of counseling in terms of dietary advice, exercise, what do they do when they become ill, say with a chest infection or with diarrhea. They need to know that they can't just stop taking their insulin. They need to potentially adjust the insulin. And in fact, type 1 diabetics often need to increase their insulin dose when they're ill because the body is requiring higher insulin levels. Okay, so a diabetic, a type 1 diabetic knows never to stop their insulin when they're sick. They will become acidotic. They will become very, very ill. Okay? So sometimes the insulin has to be adjusted, but it's never stopped. Okay, so this is again just another, this is just very similar to the slide above. This is just using a rapid acting instead of a short acting. So insulin Lispro combined with an intermediate. So they've added protamine to the insulin Lispro and it's become an intermediate insulin, meaning it has a longer duration. It takes a bit longer to start to work and it has a longer duration. That's the only difference, okay? And diabetics typically need to, especially if they're on insulin, need to have their glucose checked 3 to 4 times a day, so regular glucometer checks. Why do we want to do that? Well, when we look at someone's glucometer checks over the span of a week, say, it gives us really accurate information of how we need to adjust someone's insulin to get even better control. Okay? And when we're looking at someone's glucose control, we use a serum marker called hemoglobin A1C. So hemoglobin over the span of 3 months gets glycosylated, meaning sugar goes onto the hemoglobin. And if someone has really poor control of their diabetes, they're going to have an elevated hemoglobin A1C, or what's called a glycosylated hemoglobin. If someone has very good control of their diabetes in that 3-month interval, then their hemoglobin A1C is going to be lower. It's going to give a normal reading. So that's how we follow someone's 3-month control of their diabetes with a hemoglobin A1C. Okay, so let's just spend a bit of time talking about glucagon. So this is a medication that we use to raise someone's serum glucose during a hypoglycemic event. Okay, so now if someone comes in and they have a mildly low sugar and they're still awake, well, we can give them oral solutions of glucose to increase their serum glucose. If someone comes in confused, maybe a bit combative, they don't know what's going on, it might be difficult to give them an oral solution. Well, we have two choices then. We can give them a shot of glucagon intramuscularly. That's going to raise their serum glucose, or we can put an IV in and give them intravenous glucose in the form of dextrose, right? So glucagon is a very fast-acting hormone that's going to break down glycogen to glucose and raise serum levels. Okay. The problem with it is if we had to give repeated doses, it's a medication that causes a lot of nausea and vomiting. Okay. So, but typically one injection of glucagon is enough to raise somebody's glucose level in their bloodstream, and then they're either awake enough to drink something or eat something to raise their glucose, or we can put an IV in. Okay, so this is quite common for ambulance personnel to give during a hypoglycemic event when they go to somebody's home, or in the emergency room. If someone becomes hypoglycemic and we don't have an IV in, we can give them an intramuscular shot of glucagon. Okay, patients can take glucagon home as an injection, and somebody at home will need to know how to give an intramuscular shot in the event that someone has a hypoglycemic event and they're unable to take either a sugar candy or drink something with sugar in it. Okay, so that's really the main use of glucagon when we're talking about it in this module. Okay, so let's move away from insulins and talk about oral hypoglycemics. So these medications are typically used in type 2 diabetes, right? Because in type 1, you need insulin. And before we even get to all these different groups, some of them are going to be much more important than others, okay? So we're going to concentrate on the more common groups that are used. And there's two ways to think about, or there's two mechanisms by which these medications typically work. So they're going to either try to stimulate the pancreas to produce even more insulin. Remember, in type 2 diabetes, the pancreas is still working. It can still produce insulin, right? So there's medications such as the second group, sulfonylureas, glyburide being one of them, that stimulates the pancreas to produce more insulin, okay? Or the other mechanism is to try to reduce insulin resistance and allow insulin to perform its action more. And metformin would fall into that group. Okay, so the first one. So we've mentioned the first and second. They're very common groups in type 2 diabetes. So what are your options to treat type 2 diabetes? Increase insulin secretion or stimulate insulin secretion, or reduce insulin resistance. Okay, so that's how most of these drugs work. So always ask yourself, okay, what's it doing? Is it stimulating more insulin, or is it decreasing the insulin resistance so that insulin can work better? Okay, so that's how they function. And remember, you can be on some of these medications and still take insulin in a type 2 diabetic, right? So type 2 diabetes has a lot of options. So weight loss, very important. Proper diet, extremely important. Regular exercise, again, very important to burn off some calories and try to lose weight. And then we get into oral hypoglycemics, and if we've maximized them, we can move on to insulin therapy in combination with some of these oral hypoglycemics, and we'll get to that. Okay, so let's talk about a very, very common oral hypoglycemic medication for type 2 diabetes, and that's metformin. You're definitely going to see this medication used because type 2 diabetes is very common, and metformin is really one of the first medications that we use to treat it. Okay, so how does metformin work? It improves insulin sensitivity at the cellular level to allow glucose to go into cells with the insulin that's present. Okay, so it increases insulin sensitivity. The other thing it does is it reduces production of glucose from glycogen, right? So it stops the breakdown of glycogen to glucose. So it improves insulin sensitivity. That's going to lower serum glucose. And it's going to stop glycogen from breaking down in the liver. And that's going to improve serum glucose. This medication cannot make you hypoglycemic. It's not secreting, or it's not forcing the pancreas to secrete more insulin. So metformin cannot make you hypoglycemic. Okay? So let's talk about some adverse effects. The most severe is lactic acidosis. The most common is the gastrointestinal side effects: nausea, diarrhea, abdominal pain. Very common with metformin, which is really unfortunate because it's a pretty effective medication. But that's one of the limiting adverse effects that stop people from continuing this medication. Okay, what about lactic acidosis? So when you're taking metformin and you have a significant illness such as vomiting and diarrhea, and you become dehydrated, metformin builds up in the bloodstream. And through a bit of a complex interaction, it can lead to lactic acidosis. And this is a severe side effect of this drug. People become very ill with acidosis if they have a significant other illness, such as a pneumonia or vomiting and diarrhea, and they're on metformin. Okay? And when you have acidosis, how do you present? Well, you present very sick. You're typically breathing fast to try to blow off some of the CO2, which is trying to reduce the acid in your bloodstream. And you're often quite dehydrated as well. Okay, so lactic acidosis, the most severe. GI side effects, the most common. Contraindications. Well, we don't use metformin in type 1 diabetes, so we don't need to worry about DKA. Severe infections, that's referring to if you're on metformin and you develop a severe infection, you could be at risk for lactic acidosis. Or if you have a severe infection, we probably wouldn't start you on metformin until it's resolved. Kidney impairment can be a reason not to stop and not to start metformin, because remember, if you have kidney impairment, you're going to build up metformin at higher levels in the bloodstream. Okay, so really a first-line medication for type 2 diabetes. It can be used in pregnancy. We're careful with someone who's having to go for an imaging test that requires intravenous dye. For example, a CAT scan that requires intravenous dye because contrast media can harm the kidney, and in combination with metformin, you can have acute kidney injury. Okay, so typically patients need to stop their metformin before having intravenous contrast media for an imaging test. Okay, so glyburide is a sulfonylurea. Again, another very commonly used oral hypoglycemic for type 2 diabetes. What does it do? Stimulates the pancreas to release insulin. So can you become hypoglycemic on glyburide? Absolutely, right? So by stimulating more insulin, you can definitely go into hypoglycemic levels. Okay, and that's why when a child gets into grandma's pills or grandfather's pills and takes glyburide, we take it very seriously. And we often keep them for 24 hours of sugar monitoring because glyburide is going to stimulate the release of insulin, and they can become hypoglycemic many hours after taking the glyburide. Okay? So that's always a concern when you're taking a medication that stimulates insulin secretion, such as glyburide or another one called glipizide. Okay? And because you're stimulating insulin secretion, well, insulin is going to promote weight gain. Because what does it do? It tells the liver to store glycogen. It tells the fat cells to make more fat and store glucose in that fashion. So you typically gain weight when you are on insulin. Okay? The opposite is with metformin. You often lose weight when you're on metformin because of its gastrointestinal side effects. You're not as hungry. You tend to lose your appetite when you're on metformin. Okay, so when do you take glyburide? Typically in the morning. It's not dosed with every meal. You just take it in the morning, and sometimes it's twice a day, morning and evening. And you would monitor your glucose levels with your glucometer. Okay, the same concern would occur if you were on beta blockers, because you can become hypoglycemic on glyburide, and beta blockers could block that sympathetic warning of becoming hypoglycemic. Okay, so we're going to spend less and less time on these different groups. They're still used, and some of them are quite new, but the metformin and the glyburide group, those are really the two big groups. Let's talk about repaglinide, which is a meglitinide. Okay, that's the drug class. What does it do? Very similar to glyburide. Stimulates insulin release from the pancreas. So it can make you hypoglycemic. Okay? So these are just all different groups are trying to bring down the sugar. So just keep in mind, does it cause insulin secretion, or does it help reduce insulin resistance? Okay? So, and how do we check long-term control of diabetes? Hemoglobin A1C. Okay? Now, with most of the medications, if you skip a meal, so for example with glyburide, if you skipped a meal, you probably wouldn't necessarily need to skip your pill because it's long acting throughout the day. This is fast acting. If you skip a meal, you skip the dose. Okay? Okay, so here's another prototype drug in this drug class. I dare anyone to try and pronounce it. So thiazolidindiones, so pioglitazone, rosiglitazone. What do? Increase cellular sensitivity. So they decrease insulin resistance. Okay? So it allows the glucose to get into cells, including the liver. Look at the adverse effects. You don't see hypoglycemia on there, but you see a host of other adverse effects with this group. So patients can often retain fluid with these drugs. They can have elevated abnormal cholesterol levels. It can be a bit hepatotoxic. These can irritate the liver. And there's reports of bladder cancer with this group of medications. Okay, so the contraindications will likely make sense. DKA for sure, because we only use insulin for DKA. That's in type 1 diabetes. We would avoid it in heart failure because of the fluid retention. Anyone with a history of hepatitis or bladder cancer, just because this can irritate those conditions, we would avoid this drug. Okay? So very common to get some leg swelling and fluid retention. So monitoring is required for signs of heart failure, such as shortness of breath, increased leg edema. Okay, so acarbose is a bit of a strange one by the very fact that it doesn't really act on the pancreas, and it doesn't really act on the cells to reduce sensitivity. All it does is it acts in the gastrointestinal tract. So it's an enzyme inhibitor in the gastrointestinal tract, and it slows down the breakdown of carbohydrates. So when you have a nice spaghetti meal, which is carbohydrate, this drug is going to slow down the breakdown into simple sugars. So by slowing down the breakdown, you don't get big jumps in glucose levels in the serum. But if you're messing with an enzyme in the gastrointestinal tract, you're going to get adverse effects, right? Because you're not allowing the gastrointestinal tract enzymes to perform normally. So look at the side effects: diarrhea, bloating, abdominal pain. Those are by far the most common adverse effects to acarbose, and that would be the reason why people can't take it. Okay, and definitely this has nothing to do with insulin or insulin sensitivity or insulin release. It's just trying to slow down how fast sugar is getting into the bloodstream to not have these really high peaks of sugar levels. Okay, so typically they take they'll take this 3 times a day with the meals, and it's not a medication that can lead to hypoglycemia. Why? Because it doesn't stimulate the pancreas to release insulin. Okay, so I'm not going to spend as much time on these. You'll likely see this medication. So sitagliptan or Januvia. Again, these are all type 2 diabetic medications. What does this one do? It's going to promote the release of insulin. So can you get hypoglycemic? Absolutely, right? It's increasing insulin secretion and decreasing glucagon secretion. So you can definitely become hypoglycemic. And the reason why I'm saying that is we would really try to avoid using 2 medications that cause hypoglycemia. We're going to put someone at risk for a hypoglycemic event. Or we would really try to avoid one of these medications that can cause hypoglycemia and insulin. So we typically would never mix insulin with glyburide, because both of them are going to potentially cause hypoglycemia. Okay, so that's why I'm mentioning which ones cause hypoglycemia and which ones don't. Okay, so this particular group can also cause multiple achy joints and very rarely pancreatitis. Okay, I think if you just know that it's a diabetic medication that promotes insulin secretion, that's the most important. Okay, so another group I'm not going to spend a lot of time on, canagliflozin. Okay, Invokana is the brand name for type 2 diabetes typically. And how does this one work? Well, this one's a bit different than the I'm either going to cause insulin secretion from the pancreas, or I'm going to reduce insulin resistance, which are most of these drugs, except for acarbose that we just spoke about, which stops the big, fast breakdown of carbohydrates to simple sugars, and it stops those peak levels of sugar in the bloodstream. This one blocks glucose from being reabsorbed in the kidney. That doesn't really seem like a great idea, so now you're going to spill glucose into your urine. Bacteria love to feed on glucose, so you're more prone to urinary tract infections. You're going to urinate more because you're not able to reabsorb glucose, and you're going to take water down the nephron and into the urine, so polyuria. And if it's severe, you could develop hypotension because you're reducing your plasma volume. Okay? This could be used in combination with insulin for type 1 diabetes. It could be, because it really has nothing to do with insulin in terms of its action. I would say that would be relatively uncommon. This would be more used in type 2 diabetes. And notice this one has a really different action of how it works compared to most of the other ones. Okay, so there's another group that are called amylin analogs. So we're getting into like more and more esoteric groups, more and more expensive groups, by the way, too. Pramlintide. So what does this do? So you can see that it could be used for type 1 or type 2 diabetes. In type 1 diabetes, it could just be used in combination with insulin, never by itself, okay? And really what it's doing is it's inhibiting glucagon production. And what does glucagon do? It raises serum glucose, okay? And it also decreases gastric emptying time, okay? So again, these are all used, this is subcutaneous, by the way, and these are all used to try and lower serum glucose, again, typically in type 2 diabetes. So I'm not going to spend a lot of time on this one. I think if we spend a lot of time on these, the more important ones will be lost in all the information. Okay, and this is just a slide showing you on how this one works, pramlintide, right? So it slows the stomach from emptying. Okay, that's gonna delay how much of the sugar is gonna get into the small intestine all at once. Okay, that'll reduce plasma glucose. It's going to inhibit glucagon release from the pancreas. Okay, that's going to lower serum glucose as well. It suppresses appetite. Okay, that'll lower serum glucose. So it's working in a number of ways. But I'm going to tell you, we're getting a bit esoteric with the drugs. I'm really suggesting you focus on the sulfonylureas, the metformin, some of the earlier oral hypoglycemics. I think these ones are interesting. They're much newer. This one's, again, I mentioned subcutaneous, and they're just finding different ways of lowering serum glucose in type 2 diabetes. Okay, and exenatide, I'm not going to spend any time on. I know it's in your ATI book, and that's partly why we've added them. But again, I think if you just look at it from the point of view of what does it do, okay, it promotes insulin release. Okay, so we can use that to increase insulin levels in type 2 diabetes. I think once we get into more and more detail, you'll lose some of the more important information from other drugs. So this is just in here for completeness sake, to know that this exists. but I think knowing significant details of it is really beyond the scope of this class. Okay, so this is the last slide. I'm not going to spend any time on it. I think it's really more for just for you to see that, okay, this is a newer oral hypoglycemic. Yes, increases insulin that you can see in this slide, decreases glucagon, used for type 2 diabetes. I think that's enough. It was more for completeness sake in ATI. So this is a longer module for sure. Most of them typically have been, in the 2.5 hour range. So because this is on a lot of hormones and diabetes, it was definitely a longer module. But I hope it helps you understand the different hormones that we've discussed, the different conditions, and also gets you a good understanding of diabetes. Okay, see you at the next module.